All right, hi guys, very good evening to all of you, and welcome to our today's YouTube session where we'll be revising the syllabus of pharmacology, which are important from the examination point of view, in less than 3 hours of the time that we have. Now, for all the students, those who are new here, you can reply, you can talk to me, you can give your comments about the session or about the question that I'm asking through the live chat option that we have here. Please give a quick, confirmation if the audio and video both are fine. Arjun Balakrishnan is asking, discuss more questions. We will have some questions, but since it's a quick review of pharmacology, if I discuss questions, believe me, in 3 hours, we hardly will be able to discuss around 45 to 50 or max to max. If I reach, it will be 60. But the session that I'm going to conduct here will give you the entire nutshell of lots of, important topics of pharmacology, and rest assured that they all are mostly derived from the questions only. Okay, if everything is fine, then we can immediately start, and I'm sure all the students, those who are joining here, they're looking for some very crisp, very concise session where you can revise the important areas of pharmacology in less than 3 hours time. That is what the title says of today's class. Okay, so rest assured these 3 hours are going to be productive. Every minute that you are going to spend here with me for next 2.5 to 3 hours will be productive, that I can assure you for that. Okay, so 50% ठीक करवा दो फार्मा के. We'll try for the maximum out of this session that we have, but again you'll have to utilize some of the basics, some of the common terms that are there, that the examiner is going to use. Definitely you'll be able to do maximum out of the session that we are going to discuss. Okay, yes, I can totally understand this is going to be a pressure cooker situation, and that is absolutely a normal response. Believe me, for any student, those who are not getting this kind of feeling, they have not read it well, or maybe they have read everything. Any mediocre student, we all are mediocres, right? Any mediocre student, those who have read a little, we tend to forget. We are reading 19 subjects, and out of 19 subjects, reading, revising, doing MCQs, then again going back to point number one. This definitely can give us a little bit of anxiety. I totally understand the scenario, but again, for the next 3 hours, I want all of you guys to forget that your examination is day after tomorrow. बस 3 घंटे मेरे साथ स्पेंड करिए. मैं बता रहा हूँ, ये आपकी प्रिपरेशन का सबसे बेस्ट 3 hours होगा. However, if you have attended my review classes or crash courses before this, again you can revise it here. But again, I'm telling to all of you guys that we'll have some questions here in this session as well, some of the questions and some of the PYQs as well. Okay, so I hope all of you guys are ready, and we can immediately start the session for the day. Okay, all right, so first topic that I'll be discussing for all of you guys will be the poisonings and antidote, important poisoning and antidote that are there in pharmacology, and also which has been asked in the previous examination. Looking at the past scenarios, I'll ask the first two questions. One will be what will be the treatment of poisoning in the given scenario. So examiner can give you drugs like your aspirin, drugs like your amitriptyline, which happens to be one of the tricyclic antidepressants, barbiturates, chlorpropamide, methotrexate, imipramine. All of them are actually acidic drugs. So you all know, if there is any acidic drug poisoning, what will be the antidote of acidic drug poisoning, guys? You all know the treatment for this scenario is going to be your forced alkaline diuresis. Please do not make mistake in this one, and this is one of the questions that has forever, right? It's asked very, very frequently, and again we are discussing this. So forced alkaline diuresis, using what will you use for this one? You will be using sodium bicarbonate, or you can even use carbonic anhydrase inhibitor. So in the option, they can give you drugs like your acetazolamide, torzolamide, methazolamide, dichlorphenamide. These are all carbonic anhydrase inhibitor. Sometimes they can simply even give you to identify which of the following is a carbonic anhydrase inhibitor. Okay, so forced alkaline diuresis, point number one. So poisoning के लिए just 5 minutes spend with me. 5 minutes में पूरी poisoning को summarize करूँगा, and rest assured 1 marks from the poisoning. Poisoning से question आए, you can take it as a pharma question, you can take it as a medicine question, you can take it as a, let's say, forensic question. That hardly matters. What matters is when you are sitting in the examination, 1 mark you are finishing in the next 5 minutes. I hope all of you guys are okay here. The next one, acidic drug poisoning. How will you differentiate from acidic from the basic? They will not give you this term. They might not give you this term basic. They'll be giving you name of a drug. Okay, so drugs like amphetamine, strychnine, all the basic drugs, they're mainly ending with the ene, right? Morphine, quinine. The condition to use the diuresis modality of treatment if the antidote is not available. So basic drug poisoning, and the condition is that antidote is not available. Since antidote is already available, then definitely we can use antidote. For example, we have atropine ka antidote, right? That is physostigmine. I am pretty sure that all of you guys are already aware about this. This is going to be your physostigmine. Morphine ka kya hai? What is the antidote of morphine? We have naloxone. I'll give you the entire list as well. However, if naloxone or physostigmine is not there, if there is any basic drug poisoning, how are you going to manage? This case scenario will be managed using what? This will be managed using what? This will be managed using forced acidic diuresis. Forced acidic diuresis. Now I'm not going to give you, I'm not giving you a 4 options wale question. I'm definitely there will be 4 option wale question as well. But if I give you 4 option wale question, I'll be waiting for 5-10 seconds for your responses, and that will simply take us our time. What I want is that whatever 3 hours time that you are going to spend here, you will end up revising all the minor, major, important areas from the examination point of view, including your immunomodulators, including the important monoclonal antibodies as well. Okay. So this you are using here what? Forced acidic diuresis using what? What are you going to use? Using NH4Cl, or you can even use simple injection of ascorbic acid, that is vitamin C. Okay. Now you all know if the medium will be same, drug will be absorbed. You have to change the medium of the urine so that this compound do not get absorbed. Okay. Okay, if that is the case, then one more question that is very frequently asked, and students are often confused in the symptom of this organophosphate poisoning or carbamate poisoning. Organophosphate poisoning, carbamate poisoning versus atropine poisoning. So what is the treatment and what is the symptom? First and foremost, how will the patient present? Because they will give you, a patient is presenting with the following symptom, what is the antidote that you are going to use? So organophosphate, what class of drug are they? Organophosphate and carbamate, guys, this is going to be acetylcholine esterase inhibitor. This is one of the irreversible inhibitor of the acetylcholine esterase, and therefore the level of acetylcholine will be increased, so more and more cholinergic symptom will be there. On the other hand, atropine that we have, it is one of the non-selective muscarinic antagonists, right? So they will be blocking M1, they will be blocking M2, they will also be blocking M3, non-selective muscarinic antagonists. Because of the blocking M1, the patient can have some of the CNS symptom. The patient will also have some GI symptom. M2 blockade की वजह से there will be increase in the heart rate. This is where you are going to see heart rate will be increased. M2 mainly present on the heart nodal tissue. M3 blockade will lead to what kind of problem? Okay, so there will be decrease in the glandular secretion. There will be decrease in the glandular secretion. Because of the decrease in the glandular secretion, what will be the outcome, guys? Because of the decrease in the glandular secretion, there will be dryness. You can even understand there will also be increase in the body temperature. M3 is also present on the circular iritis muscle. Because of that, what will be the outcome, guys? Circular iritis muscle responsible for the constriction. If you block this, there will be dilatation. So there is also going to be a mydriasis. So just remember, atropine may everything will be on the top. What all things will be on top? Let's repeat again. There will be heart rate will be on top. Body temperature will be on top. Pupil size will also be on top. Atropine. On the other hand, organophosphate carbamate, there will be all cholinergic symptom. Again, if I just simplify this with the simple 3 symptom, one of which will be secretion. So there will be excessive secretion because more and more cholinergic symptom will be there. Secretion will be definitely high, right? What happened to the heart rate? What happened to the heart rate? The heart rate will be lesser. What happened to the pupil size? There will also be pinpoint pupil. There will be miosis. Sometimes it is also termed as a pinpoint pupil. However, pinpoint pupil can also be seen in many other scenarios. Okay, like morphine poisoning, pontine hemorrhage, and in all of them. I hope all of you can easily distinguish between these two. Okay, if you can easily distinguish, then why not discuss about the treatment of this one? How will you manage? Let's talk about this. Okay. So for the management of organophosphates, what's the antidote of choice? What is the antidote of choice for the management of this organophosphate or carbamate? We will be using our very own atropine. Okay. Pretty simple. And for the atropine poisoning, what will you use? What will you use this here? You will be using physostigmine. However, In a case of organophosphate poisoning, we can even use oximes. Oximes will not be effective in carbamate poisoning. Oximes can also be used mainly in the organophosphate poisoning. Now the basic reason why it is not effective and all we have already discussed in our regular classes, that okay, oximes will be acting, organophosphate will be acting on usually on the esteric side, carbamate will be binding anionic and esteric side both. So we need one vacant site for our oximes to work. So oximes will be binding at the anionic side and they will be making a bond with our organophosphate and they will dissociate from the site. Okay, so that is why in carbamate poisoning oximes are not going to be effective. Clear? Again, there is one more poisoning and this we have covered already. Atropine, organophosphate, FMGE exam mein question will definitely be there from these important areas. Apart from that, I am also expecting the important antidotes. So quickly let me just summarize. Like atropine ko, as I have told you that we are going to use antidote like physostigmine. Let's quickly summarize physostigmine. Here the antidote will be naloxone. This table we have been discussing from many examination, and luckily in 2022 examination we got 5 questions in NEET PG just from this important table. For copper poisoning we will be using D-penicillamine. Do remember D-penicillamine is also the drug that can be used in your Wilson disease for chelating the copper. Iron poisoning we will be using desferrioxamine. Now examiner can give you that which of the following is the oral chelator of the iron. For that case scenario, you will be using the oral chelators. What is the oral chelator for the iron that we have? We have agents like your deferriprone, and we also have one more agent known as your deferrasirox. Now this is very easy. In the examination, you don't have to worry. Why? Because your answer is in front of you. You just have to choose, right? Deferriprone, फेरिक वाले के लिए है ना, डेफेरासिरोक्स, अगेन डेफेरासिरोक्स. इंजेक्टेबल वाला कौन सा है? Desferrioxamine is the injectable one. Deferriprone, deferrasirox, these are given by the oral route. These are the orally available one. Okay. Lead poisoning में what can you use? Lead poisoning में we can use BAL, we can also use EDTA. Paracetamol poisoning में we can use N-acetylcysteine. Examiner asks in one of the examination what is the intermediate toxic metabolite of paracetamol, that is NaPQI, which everyone knows I guess. Digoxin के लिए we will be using digibind, the fab fragment that will be acting as the chelating agent. So again this digibind is acting as a chemical antagonist of digoxin, remember that. Okay. Benzodiazepine के लिए क्या यूज कर सकते हैं? Flumazenil. And beta blocker के लिए we can use glucagon. So many of the antidotes that we have, one question from antidote is definitely going to be asked, right? Acute में we will be using injectable one, desferrioxamine, right? अगर किसी को recurrent blood transfusion हो रहा है, right? So in that case scenario we can use the oral one, deferriprone or deferrasirox. Dr. Ankit, acute condition में injectable one is the preferred agent. I hope all of you guys are okay here. Antidotes, important questions on antidotes are done. Now एक और question जो मैं expect कर रहा हूँ in upcoming examination, antidote तो होगा but general antidotes नहीं होगा. It can be an antidote from the hematology topic. So since we are discussing antidote, I'll take this opportunity in the next 1 minute. I'll be giving you antidotes of this one. Whenever there is a warfarin toxicity, we all know that warfarin के लिए we'll be doing the extrinsic factor का monitoring, and for the monitoring what will you use? I think I have given you already the mnemonic that war is done from external forces, and for that we'll need the physical training at the international level. Okay, so warfarin के लिए monitoring will be done by what? PT-INR. And antidote of choice क्या use कर सकते हैं? We can use vitamin K1. However, if the bleeding is there, regardless of the PT-INR, if the patient is having bleeding, we will be using fresh frozen plasma. We are going to use what? Fresh frozen plasma. We can also use heparin के लिए again we will be using protamine sulfate. Examiner asks, okay, which kind of antagonist is protamine sulfate? So protamine sulfate, again it's a chemical antagonist for the heparin. How will you do the monitoring for this one? Again very easy. If warfarin, war is done with the external people, war is done with the external people, the extrinsic factor की monitoring, and for this physical training at the international level is very important. Then heparin will be again uska ulta. So monitoring will be done with your APTT. 10A inhibitor. So which of the following is a 10A inhibitor? We all know drugs like your apixaban, edoxaban. ये 10A पे ban लगाते हैं. Edoxaban, betrixaban. Very easy to remember their name. 10A पे बैन लगाने वाला ड्रग. So whenever there is any overdose of this one, which has already been asked in one of the NEET PG examination, 10 inhibitor, we'll be using a drug known as your Endixanet alpha. So I'm writing small and capital just to make it very very easy. ये 10A को neutralize करने वाले drug है. These are the drugs that are going to neutralize 10A. Okay, apixaban, edoxaban, betrixaban, rivaroxaban, these are all 10 inhibitor, direct 10 inhibitor, है ना? So इनका you can remember the antidote will be 10A को neutralize करने वाला drug, that is your Endixanet alpha. Dabigatran that we have, direct thrombin antagonist. Dabigatran will be your directly acting thrombin antagonist. This dabigatran के लिए you will be using antidote that is your idarucizumab. इदारुसीजुमाब जो क्लास में मैं कई बार आपको बोल चुका हूँ. Dabigatran दबा के दारू will be idarucizumab, just a way to remember. Streptokinase, this is one of the tissue plasminogen activator, mainly preferred in a condition like ST elevation MI. Okay, you can also use in many other conditions, but streptokinase का overdose हो जाए, so we will be using epsilon aminocaproic acid. We can also use one more agent that is your tranexamic acid, readily available, very commonly used in many other conditions. ठीक है, tranexamic acid is the alternative drug. So lot of antidotes we have discussed in the past. I think around 10 minutes में, and one topic we have covered. 10 minutes में one question we have covered. And what kind of question has been asked? As I told you, in just last examination they asked 5 questions. So one of the question was this: female presented with the TCA toxicity, right? So TCA will be associated with your problem known as your metabolic acidosis. This can also induce arrhythmia, can also lead to some QRS changes and QT prolongation as well. Okay, what is the treatment? So we already know that if there is a metabolic acidosis, they will be inducing arrhythmia. What kind of drug you are going to use? IV, sodium bicarbonate. I think it's very very easy. You're not going to use ascorbic acid or NH4Cl or atropine. Very good. One more question that was asked: a patient on digoxin therapy consumed 8 tablets of digoxin. Again, digoxin is a drug that is having a narrow therapeutic index. We all know that, and because of this we need to do therapeutic drug monitoring. So this is one more topic that will be covered today, and each having 0.25 milligram. He is coming with a heart rate of 56, so heart rate is already lesser. Okay, so severe toxicity is also there. Most appropriate therapy. So what are you going to most appropriate therapy in this case scenario is going to be, again your answer for this question will be your digibind, digoxin ka fab fragment, digibind, the fab fragment that will be acting as a chelating agent. A patient presented in emergency with acute poisoning of opioids. Again, see opioid poisoning. Have I already given you the antidote? So we already know the antidote for this one will be your naloxone. Now examiner can ask you, okay, if naloxone is not there, what is currently the alternative? In 2022 February, that means just एक साल पहले, there was a drug that was also got approval for this one, that is known as your nalmefene. Nalmefene is an alternative. It's also a opioid receptor antagonist. It's same as your naloxone. ठीक है, nalmefene is an alternative that you can also use. There is no role of atropine here. Naltrexone, what is the main role of naltrexone, guys? It is mainly utilized in a de-addiction therapy to prevent the relapse. After the methadone substitution therapy, will keep a 10-day gap. How many days gap I said? 10-day gap, and then you start the naltrexone. Okay, great. Next one. A patient consumed 20 tablets of paracetamol. So you can easily understand the antidote of choice, paracetamol poisoning. Then in one question they ask what is the intermediate toxic metabolite, है ना? So intermediate toxic metabolite for the paracetamol poisoning, it is going to be NAPQI, that causes your fulminant hepatic failure. Okay. N-acetylcysteine is the antidote of choice, which we already know this. One more question that was asked, NAPQI, as I said, and this was all just asked in just 1 to 2 years. एक ही एग्जाम का क्वेश्चन था 5 इसमें से. So NAPQI is the toxic metabolite of what? Paracetamol. एक और क्वेश्चन ले लेते हैं, then we go to the next topic. 11-year boy presented to emergency with vomiting. Parents give a history of consuming 8 tablets. Right? I have already discussed 2022 का recall session. Check it out. You will find all these 5-6 questions that has been asked. So consuming 8 tablets of iron. So what is the antidote for the iron in this scenario? Again, acute toxicity or patient vomiting is a GI symptom will be very very predominant here. Okay. So what will be the antidote here? Again, the answer for this one will be your desferrisamine. Depenicillin will be used mainly in the copper poisoning. Okay. So one question, antidote. I think antidote जितने भी थे सारे antidotes को we have covered. Rest assured, you will be having one case-based scenario, either organophosphate, carbamate, and oximes, atropine. Definite question will be there. Okay, this is on the basis of the experience only. Drug schedules and categories. Again, schedule, which category? Nowadays there are a lot of questions on teratogenicity. एक बार मैं फिर से बोल रहा हूँ, टेराटोजेनिसिटी पे एक्सपेक्ट करिएगा एक क्वेश्चन, आइदर देयर विल बी अ इमेज or they'll give you a scenario that a patient presented in pregnancy, she had epilepsy or she had this problem, and now the patient is presenting with this symptom. Which drug would have been possibly given to the patient at that point of time? All right, so let's quickly revise schedule and category. So how much time have I given? How much time have been I have given for this one? Schedule and category के लिए 10 to 12 minutes I have allotted. And again, क्या हो गया? Some problem? Let me see. Sorry about this short interruption. Okay, I think we are back. Please give a quick confirmation if everything is fine. All the students, those are live. All cool. Okay, great. So next 10 to 12 minutes we'll be spending for schedule and categories. Teratogenicity पे believe me, there will be definite question, because this is one of the very hot topic nowadays. In almost every examination they are asking question, and if you will be lucky you might get 2 question, because one from schedule, one from category. So next 299 के लिए ध्यान रखिए, 1 मार्क्स आपने कर लिया, टॉक्सिसिटी एंटीडोट जितने थे, राइट। नाउ अगले मार्क्स के लिए हम बात करेंगे अगले 10 मिनट्स में, ठीक है। नाउ इंपॉर्टेंट शेड्यूल एंड कैटेगरी, इफ यू गाइस हैव एवर अटेंडेड माय सेशन, आई यूज्ड टू गिव यू अ वेरी नाइस स्टोरी अबाउट द इंपॉर्टेंट शेड्यूल्स दैट वी हैव, एंड लेट्स क्विकली डिस्कस व्हाट आर द डिफरेंट शेड्यूल्स। रिमेंबर, इन यूनाइटेड स्टेट्स दे आर प्रैक्टिसिंग ओनली एलोपैथी मेनली, एंड दे हैव शेड्यूल्स, 5 शेड्यूल्स, 1 2 3 4 5 in Roman letters. In our country we are practicing multiple schedules. क्या क्या प्रैक्टिस कर रहे हैं? एलोपैथी is just one of them. Mainly आयुष सिस्टम लाइक आयुर्वेदा, सिद्धा, यूनानी, है ना, कितने सारे हमारे पास, है ना, एंड एलोपैथी जस्ट वन ऑफ देम. सो आवर शेड्यूल इन इज फ्रॉम लेटर ए टू जेड. कितने हैं? ए टू जेड. और उसमें भी कई के वेरिएंट हैं, जैसे एच का H1 है, आर का R1 है ना, मल्टीपल शेड्यूल्स के वेरिएंट हैं. यू डोंट हैव टू रिमेंबर ऑल दो शेड्यूल्स. व्हाट इज इंपॉर्टेंट, जस्ट 4 to 5 शेड्यूल जो मैं बोल रहा हूँ उसको रट लो, काफी है, ठीक है. मैं बताऊंगा 7 to 8, बट आपको पढ़ने कितने? 4 to 5, राइट. सो शेड्यूल, दिस इज अकॉर्डिंग टू ड्रग एंड कॉस्मेटिक एक्ट. यूनाइटेड स्टेट में US FDA एंड हमारे यहाँ पे ड्रग एंड कॉस्मेटिक एक्ट. सो शेड्यूल्स के लिए वी हैव डिफरेंट शेड्यूल इन इंडिया, बट दूसरी जो टॉपिक है कैटेगरीज, दिस कैटेगरीज इन आवर कंट्री इज ऑल्सो फॉलोड द सेम, जो हमारे यहाँ जो है वो फॉलो द सेम रूल ऑफ US FDA. US FDA का हम फॉलो करते हैं. इसमें है कैटेगरी A, B, C, D एंड X, ठीक है, A, B, C, D एंड X. शेड्यूल्स जो है, दिस इज योर ड्रग एंड कॉस्मेटिक एक्ट. इन आवर कंट्री वी हैव ड्रग एंड कॉस्मेटिक एक्ट 1940. सो इसके अकॉर्डिंग हर ड्रग के बारे में, विच टाइप ऑफ ड्रग इज देयर, हाउ टू मैन्युफैक्चर, व्हाट इज द शेल्फ लाइफ, एवरीथिंग हैज बीन गिवन इन आवर दिस ड्रग एंड कॉस्मेटिक एक्ट. इफ एनी वन इज हैविंग प्रॉब्लम इन द video quality, please do set the video at quality, high quality, advanced, like 720 480 पे अगर आप करते हैं तो you will not have poor quality, ठीक है. All right. So important schedules that we have, let's quickly talk about important schedules. Okay, which of the following schedule deals with the biological and special product like insulin, toxin, antitoxin? Biological product, insulin, toxin, antitoxin. B for biological product, we are going to talk about the schedule C, right? Give the list of substances under Ayurveda, Siddha and Unani. As I said, the list of poisonous substances, this will be coming under schedule E. Regulation and standard for running a blood bank includes vaccine and serum as well. This will be your schedule F. So everything should be frozen in the blood bank. Remember, details the drug labeled with caution. So this is going to actually give you a guideline, right? And it should be given only under the medical supervision. Given we are talking about intake, and this one will be your schedule G. Hormonal, anti-cancer and all should be given under medical supervision. Intake की बात कर रहा हूँ मैं, ठीक है. Sold by retail only on prescription of RMP. This will be your schedule H. RMP, कौन है RMP? हम सब हैं RMP. We are all RMP. What is RMP? Registered Medical Practitioner. Expiry period, this will be your schedule number P. Drugs which shall be marketed only under generic name, जो worldwide same name से available है, that will be generic, right? Drugs which shall be marketed only under generic name, schedule W. Psychotropic drug, again psycho, तो मैंने आपको बताया भी होगा. Whenever it comes to psycho, remember all your X's, right? X's को याद करिए, and rest of the thing will be very very easy for you. And remember, they also have high abuse potential. So ये भी एक अच्छी बात है, कि X's have high abuse potential. Can you give me some example of Schedule X drug? Schedule X का कुछ example बता दीजिए, which has been asked already in the previous examination, like your opioids. We have ketamine, LSD, those who have high abuse potential, and you cannot directly go and buy. Even if you're a doctor, you cannot simply go and procure this drug. Okay, specify the requirement and guideline on clinical trial. So whenever it comes to clinical trial, do remember you should always think about Schedule Y. Why should I prescribe your drug? Why should I prescribe your drug? So the MR will say, sir, let's do a clinical trial. In one group you can give your existing drug, and in other one I'll be giving you my drug, and we can find out whether which drug is effective here. Okay, so again let's quickly see that what all the schedule that we have. Clinical trial, how will you remember? Clinical trial, why should I give your drug? Okay, why should I give your drug? Then we are having X. Remember, you have to remember your X who was a psycho. Just remember, अगर अभी भी कुछ attachment है तो sorry about that, but just remember your access with psycho, and just remember it is also, he or she has also high abuse potential. नहीं है imaginary बना लो till examination. Okay, W जो वर्ल्ड वाइड उसी नाम से अवेलेबल है, that will be schedule. W, P for period, very easy. Again P for period, expiry period है ना, तो नॉट वेरी इंपॉर्टेंट एक्सपायरी पीरियड, बिकॉज इसमें क्या एग्जामिनर पूछेगा, ऑलरेडी पता है P फॉर पीरियड. देन H फॉर जो हम देंगे, कौन है हम सब हैं RMP. बोलिए कौन देंगे, हम देंगे. हम कौन है, हम सब हैं RMP, रजिस्टर्ड मेडिकल प्रैक्टिशनर. द वन दैट गिव्स यू गाइडलाइन दैट दिस शुड नॉट बी गिवन एक्सेप्ट अंडर मेडिकल सुपरविजन. ओके, इन अ ब्लड बैंक एवरीथिंग शुड बी फ्रोजन. सो F for running a blood bank. Remember, there is someone called double F, that is for all the ophthalmic drug, but single F is for you running the blood bank. E, right, whenever you eat anything, this Ayush system wala, they are not very flavorful, like orange flavor or strawberry flavor, they always are little bitter in tasting. So whenever you eat anything bitter, what is the expression for from your mouth? जब कुछ bitter खाते हो तो मुंह से क्या निकलता है, जो expression is E, है ना. So the one that bring E from your mouth, that will be E. And C, this is mainly for the biological, right? So ये एक आपके NMC के इनफैक्ट गाइडलाइन में इसका जहाँ पे सिलेबस दिया उसके एग्जाम्पल में भी इसका जिक्र है. सो सिलेबस में भी इसका जिक्र है बायोलॉजिकल ड्रग्स के लिए, तो वी कैन एक्सपेक्ट C वाला, राइट. आई होप एवरीवन इज ओके हियर. And we got disconnected once again. I don't know, due to unknown reasons. What's happening? Okay. Again, we are done with the schedules. Now, what was the one question that was asked and student got confused between Schedule X and Category X? Category में remember एक T आता है. Category, भाई हो जा जल्दी connect. Category is a T. T for teratogenicity. Okay. Sorry about this short interruption. I don't know, आज ये सब problem हो रहा है. Okay. Now US FDA has given the drug risk classification according to the risk of teratogenicity, and whenever it comes to category, remember category में एक T आता है, T for teratogenicity, T for teratogenicity. Remember that the safest among all of them, who is going to be the safest among all of them, it will always and always be category A drug. It can be given animal human model, show no risk to the fetus. Then comes the B. They have not done animal study, but human model. They have not done human study, but animal model shows no risk to the fetus. C, certainty is not decided. They are not certain that whether it's going to be teratogenic or not, and also there has been no reported teratogenic risk as well. Again, so A, B, C हो गया. Next in the line will be your D. D can be given. D को दे सकते हैं. कब दे सकते हैं? If the benefit is more than the risk. अगर D बोलता है I have more benefit, please give me, you can give if the benefit is more than the risk. D can be given, like let's say diazepam in pregnancy. If there is epilepsy, you can give anti-tubercular drug, although they are risky, but if the benefit is more than the risk, you can give. But what cannot be given, once again, X. No matter whatever benefit they offer, please don't go after the X. No matter what is the benefit, no possible benefit can outweigh the risk. No possible benefit that can outweigh the risk is more. So X वाला ड्रग नहीं देना है. X शेड्यूल कौन सा था? साइकोट्रोपिक ड्रग, अगेन वेरी डेंजरस ड्रग, है ना. एंड X शेड्यूल, प्लीज रिमेंबर, this is also X category that we have. These are all very teratogenic drug, and you should not be giving them. Okay, so what are the important teratogenic drug? Again, I'll be giving you 10 to 12 important teratogenic drug. Just remember and expect their important images as well. Okay, so warfarin, fetal warfarin syndrome, valproate causing spina bifida, thalidomide. Let's make a list very quickly. Can we make a list very quickly for all of you? Let's make a very quick list, all of you. Yeah, thalidomide. So phocomelia. Thalidomide will be causing what? Phocomelia. So there will be absence of long limb bones. Absence of long limb bones, right? Remember. Phocomelia. Have you seen the image? I'm pretty sure, and I'll be giving you in this PDF. When I'll be sharing this, you'll be getting the images as well. Okay. Valproate that we have, this will be causing spina bifida, one of the neural tube defect known as your spina bifida. Spina bifida. What about our phenytoin? This will be causing your fetal hydantoin syndrome. Now, examiner sometime can give you the characteristic feature of the fetal hydantoin syndrome. So what could be the possible characteristic feature? The examiner can give you that there will be cleft lip and palate. Cleft lip and palate. What else? Microcephaly. Everything will be small. Coarse facies. Microcephaly, coarse facies, short digits. Thin upper lip, all of them, these are all going to be the feature of your fetal hydantoin syndrome. Okay, now next will be your warfarin. Always remember that warfarin second third trimester ka drug of choice, anticoagulant of choice in second third trimester. So a patient is presenting in the 20th week of pregnancy. What is the anticoagulant of choice? You can use warfarin. Till 13th week you will be giving your heparin or low molecular weight heparin. Warfarin, remember, in the first trimester, it can, if it is exposed, it will be causing your fetal warfarin syndrome, also given the name as a Contradi syndrome. There will be facial and skeletal defect. Facial and skeletal defect. The other name of Contradi syndrome is also known as your fetal warfarin syndrome, FWS, fetal warfarin syndrome. Methimazole will be causing what? Aplasia cutis. Aplasia cutis. Fetal goiter, choanal atresia. It can even lead to your esophageal atresia. Methotrexate, predator hai, hydrocephalus, cleft lip and palate. Isotretinoin will be causing craniofacial and CVS defects. Lithium, everyone's favorite, Epstein anomaly. Epstein anomaly, and isn't that all of you guys are already aware that tin se banta hai box? Therefore, on the chest X-ray, you will be getting a very characteristic known as box-shaped heart. And it has already been asked in 2019 FMGE examination. I have already incorporated in FMGE solutions. You must have seen that. Diuretics, they will be causing growth retardation. And they can also lead to your renal agenesis. Renal agenesis. ACE inhibitors likewise can also lead to your growth retardation. One more problem. ACE inhibitors, remember, ACE inhibitors, ARB, they are always contraindicated throughout the pregnancy. Okay. Chloramphenicol. They will be leading to a very characteristic known as your grey baby syndrome. Cotrimoxazole, this will be your cotrimoxazole. Kernicterus. The other name of this one will be your yellow baby syndrome. So दो baby हो गए आपके पास, grey baby, yellow baby. Fluoroquinolone, they will be leading to what? Tendinitis, arthropathy. Do remember this tendinitis and arthropathy, it can also be a side effect if it is given to adult population, right? Can also lead to tendon rupture. Tendon rupture. 2021 NEET PG question. Erythromycin, it will be leading to congenital hypertrophic obstructive pyloric stenosis. So what will be the clinical picture of this one? Congenital hypertrophic obstructive pyloric stenosis, newborn with olive shaped lump in the epigastric area. Has it been asked? FMG already been asked. Okay, non-bilous vomiting. Always remember non-bilous vomiting and olive shaped lump in the epigastric area. Which of the following drug exposure could have caused this one? Okay, so either ये पूछेगा कौन सा ड्रग या पूछेगा सर्जरी का भी क्वेश्चन आता है, which surgery you will be doing here. Okay, diethylstilbestrol, they will be leading to what? Vaginal carcinoma. Okay, clear cell vaginal carcinoma in the female child. Okay, misoprostol, that will be leading to what? Mobius syndrome. Let's quickly revise. Mobius syndrome, misoprostol. should not be given. Streptomycin will be leading to your ototoxicity. It can also lead to a nephrotoxicity. Again, this is one of the drugs that should not be used throughout the pregnancy. Multiple time repeated question. Which of the following anti-tubercular drugs should not be given throughout the pregnancy? Streptomycin. At present, it is no longer under our anti-tubercular TB treatment guideline. I mean, it has anti-tubercular activity, but still it is not in our drug list. है ना? जो anti-EP use कर रहे हैं उसमें we are not giving injectables. So streptomycin again, it's an injectable agent. We don't have. COX inhibitor, if it is exposed in the third trimester of pregnancy, it will be leading to premature closure of ductus arteriosus. Premature closure of ductus arteriosus. Now, each of these question, if I show you, like let's say on this slide, if we have 8-9 teratogenic effect, there will be 8-9 question. Each one of them has been asked already. Okay. Premature closure of ductus arteriosus, you can check it out. This question has already been asked. Quinine will be causing side effect like retinopathy, congenital deafness. Amphetamine can also lead to hepatic calcification of arteritis. Hepatic calcification of arteritis. See, no drug is 100% safe in pregnancy. Always remember. And in fact, your safest drug, we say that paracetamol is very, very safer. In fact, it is also not safe drug. In recent studies, recent papers are saying that the mother, those who have been exposed excessively with the paracetamol, the baby is born with hyperactivity disorders. Okay. So remember, no drug is 100% safe in pregnancy, but again, the one that can cause lots of teratogenicity has been given in these two lists. So please do remember these two lists, and we can expect one teratogenic either on the basis of image. So phocomelia का image सबको पता है, and this image of this one neural tube defect spina bifida सबको पता है, this one है ना. So they will be giving you a baby here, है ना, एक baby का image दे देते हैं ये लोग, right? And here on the back side of the baby, here you will be seeing a tuft of hair will be there, or there will be exposed spinal cord, right? So ये एक image आ सकता है आपके एग्जाम में. Phocomelia का image everyone knows, phenytoin, fetal hydantoin syndrome. So these are the characteristic feature. Remember that, है ना. Flat face sheets के साथ आता है, skeletal X-ray देता है. So this will be mostly a case of fetal warfarin syndrome. Aplasia cutis, already this question has been asked, है ना. तो scalp defect they show, है ना. So I'm pretty sure that all of you guys are done here. So two important questions we have done in just 20-25 minutes. Now let's talk about the next one. I hope all of you guys are okay here. Can we proceed further? We'll simply increase the speed. Don't worry guys, don't worry, है ना. स्पीड हम इंक्रीज करेंगे, बट अगेन आप लोग ऑलरेडी काफी ज्यादा स्ट्रेस में हैं, और मैं बहुत तेज जाऊं तो और स्ट्रेस दे सकता है, विच आई डोंट वांट ऑफ कोर्स, है ना. तो सम ऑफ यू मे बी थिंकिंग ओके सर ये पढ़ा चुके हैं, क्यों बार बार पढ़ा रहे हैं, बट अगेन दीज आर इंपॉर्टेंट टॉपिक, सो डेफिनेटली वी हैव टू चेक इट आउट. सो इफ एवरीवन इज कंफर्टेबल वी कैन टेक द नेक्स्ट वन. सो नेक्स्ट 30 मिनट्स में हम जनरल फार्मा, और नेक्स्ट 10 to 15 मिनट में हम एएनएस को कवर करेंगे, है ना. सो इससे क्वेश्चन कितने आते हैं? डेफिनेटली जनरल फार्मा से 2-3 क्वेश्चन, एएनएस से 1-2 क्वेश्चन आते ही आते हैं, ठीक है. So I hope all of you guys are okay here. We can start. Yes. Okay, great. Now one question, जो कि कोई भी एग्जाम जब बनता है, पेपर बनता है, तो उसी इस टॉपिक से क्वेश्चन ना आए ऐसा पॉसिबल नहीं है, ठीक है. आप उठा लीजिए नीट पीजी, INICT, डेफिनेट क्वेश्चंस आर बीइंग आस्क्ड. क्लिनिकल ट्रायल, सबसे पहले मैं इसके बारे में बात करूंगा. नाउ फर्स्ट एंड फॉरमोस्ट क्लिनिकल ट्रायल इज डन ऑन ह्यूमंस, बट बिफोर यू डू द क्लिनिकल ट्रायल वी विल बी डूइंग व्हाट? प्री-क्लिनिकल ट्रायल. Now preclinical trial, it is actually done on the animals. Question number 1, that what is the name of guidelines? This question has been asked already, included in FMGE Sol. You must have done this already, and I'm pretty sure all the students, those who are going to appear for day after tomorrow examination, you have done your FMGE solution, I believe, yes, because वहां से questions topic repeat होते रहते हैं ना. So on the animals it is done, and this is done according to a guideline. And what is the name of guideline? Can I get a quick recall? Anyone? According to what is the name of a guideline? According to Good Laboratory Practices Guideline, GLP I have written. Please take note of complete name. GLP will be Good Laboratory Practices. So lab में कौन, laboratory में किसको रखते हैं? Animals को रखते हैं, है ना. Good Laboratory Practices, just a way to remember. Once you have got your result of preclinical trial, then you will be writing to the authorities. What do you mean by authorities? Like for example, you can write the authorities a letter known as your investigational new drug application, IND. So examiner will be asking, when will you apply IND? Before the preclinical trial or after the preclinical trial? Your answer will be after preclinical. Next, before the clinical trial or after clinical trial? Before the clinical trial, because IND क्या होता है? Investigational new drug application, investigational new drug application, it should be given prior to the clinical trial, that yes, I wanted to do trial on the human and these will be my criteria, and you'll be writing to the authorities. So who are the authorities? Like let's say Drug Control General of India, or you can even write to US FDA, depending कि किस साइड पे आप ये ट्रायल कर रहे हैं. ठीक है. Now after this one you'll be once you are getting a permission to go, you will now be doing the clinical trial. So again, next question. Clinical trial is done according to, or first question, it will be done on it will be done on humans. Now healthy human or patient, that depends on which phase of clinical trial, and this will be done according to GCP guideline. What is the meaning of GCP guideline, guys? Good clinical practices guideline. GCP guideline, good clinical practices. Do remember GCP clinical practices, GLP laboratory practices. Okay, GCP guidelines. And after this one, once you are done here, then again you will be writing the next application, and the next application that I am going to write was a part of 2022 NEET PG question. Okay, so next time you are going to write the application, and this time the name will be your NDA. राइट, पहले क्या था? इन्वेस्टिगेशनल न्यू ड्रग एप्लीकेशन, अब इसका नाम पड़ गया एनडीए. सो व्हाट इज एनडीए? दिस इज योर न्यू ड्रग एप्लीकेशन. एनडीए इज न्यू ड्रग एप्लीकेशन. यू कैन डाउनलोड द पीडीएफ फ्रॉम एनी ऑफ द टेलीग्राम ग्रुप लिंक दैट वी हैव. अनअकैडमी का टेलीग्राम ग्रुप है, वहां से मेरे टेलीग्राम ग्रुप से यू कैन डाउनलोड इट वेरी वेरी इजीली. ओके, नाउ आफ्टर दिस वन, आफ्टर दिस अगेन यू विल बी राइटिंग. सो रिमेंबर, पहले जो आईएनडीए है उसको अप्रूवल में अराउंड 1 मंथ टाइम लगता है. आईएनडीए कितना टाइम लगेगा? 1 मंथ. 1 मंथ में DCGI और USFDA have to reply that okay, you can go ahead. However, if there is some further questioning, they can sometime take some time, but usually on an average 1 महीना टाइम. But NDA में 1 साल. IND India, IND 1 month. NDA new drug application. Now you have to launch the drug in the market, so definitely they will take more time. So clinical trial you will be doing like let's say phase 1. Then you will be doing phase 2, then you will be doing phase 3. Once NDA is going to give you permission that okay, you're 1, 2, 3 good to go, you can launch the drug in the market with the new drug status, right? Launched, and marketing will also be started. The drug will be launched in the market, and at this point of time you can actually do phase 4 of the clinical trial. अब आप phase 4 of the clinical trial कर सकते हैं, which is also known as your post marketing surveillance. Okay, now first and foremost, as I have asked a simple question, that which of the following will be done on the normal healthy volunteers? Can you tell me, guys? On normal healthy volunteers, which of the following will be done on a normal healthy volunteer? Question number 1. So on a normal healthy volunteer, definitely you will be doing 1, but in FMGE 2018 they did not give 1. There was one more option, that is phase 0, which is your microdosing study, which I'll be talking subsequently on the next slide. Then again, question number 2, that maximum failure risk is occurring in which phase? Maximum failure risk. So only the whatever studies that are coming in the phase 2 for the very first time, when you are going to expose the drug to the patient, maximum risk of failure will be there, है ना? So only 25% सक्सेस रेट होता है. कितना सक्सेस रेट होता है? 25%. ठीक है. So maximum failure rate will be there in the phase 2 clinical trial. Then again examiner asks, okay, patients are enrolled for the very first time. Patients are enrolled for the very first time in which phase of clinical trial? So for the very first time you will be enrolling the patient in phase 2 of the clinical trial. Remember, there is one condition here. Again, if there is let's say antiretroviral drug, immunosuppressant drug, in that case scenario, from phase 1 only you will be starting the sample, that will be your patients. Okay, all right. Now which of the following will be a open label trial? ओपन लेवल ट्रायल कौन सा होगा? रैंडमाइजेशन नहीं करेंगे, ओपन लेवल. दैट मीन्स एवरीवन इज अवेयर हु इज टेकिंग व्हाट काइंड ऑफ ड्रग, व्हाट इज द पॉसिबिलिटी आर. सो कैन यू टेल मी विच ऑफ द फॉलोइंग विल बी ओपन लेवल ट्रायल? ओपन लेवल, एवरीवन इज अवेयर हु इज टेकिंग व्हाट काइंड ऑफ ड्रग एंड व्हाट कुड द पॉसिबिलिटी आर. सब कुछ इन्फॉर्म करके किया जाता है ना? ओपन लेवल ट्रायल. ओपन लेवल ट्रायल विल बी फेज 1 एंड ऑल्सो फेज 4. 1 and 4, 1 and 4 दोनों ही ओपन लेवल होते हैं. प्लीज रिमेंबर 1 and 4 ओपन लेवल. नाउ एक और बड़ा न्यू सा क्वेश्चन मैंने देखा जो आपके अनअकैडमी के ग्रैंड टेस्ट में था, दैट वॉलंटियर्स आर रिक्वायर्ड इन विच फेज. प्लीज रीड क्वेश्चन नंबर 1 एंड नाउ आई मीन इन दिस पेज दिस क्वेश्चन नॉर्मल हेल्दी वॉलंटियर्स, ये अलग क्वेश्चन हो गया, बट दिस टाइम आई एम आस्किंग वॉलंटियर्स आर रिक्वायर्ड इन विच फेज ऑफ क्लिनिकल ट्रायल. Now your answer for this question should be that guys, volunteer will be needed in all the phases, right? So volunteers will be required in all phases of the clinical trial, right? That means they have to volunteer, they have to sign the consent form that yes, I want to take a part in this one, and there is no problem, you can enroll me in this particular studies. Okay, so volunteers will be required in all phases of clinical trial. Let's quickly do a very important table, right? Which all of you guys must be missing so far. The aim of the phase 1 clinical trial, which is usually done on normal healthy volunteers. It is usually done on the normal healthy volunteers. Okay, what is the aim? To determine what? To determine the safety. We also study that maximum tolerable dose is assessed in which one? Maximum tolerable dose assessed in this which one? Again, phase 1. Phase 1 में हम फार्मेकोकाइनेटिक स्टडी भी कर सकते हैं. वी कैन ऑल्सो डू फार्मेकोकाइनेटिक स्टडी एज वेल. ओके, व्हाट अबाउट द सैंपल साइज बॉयज एंड गर्ल्स? सैंपल साइज फॉर फेज 1 विल बी अराउंड 25 to 100. 25 to 100. However, the recent Goodman-Gilman 14th edition, they have changed the number 10 to 100. So even as less as 10 also you can take 10 to 100. है ना? Study design, it will be an open label study. It will be an open label study. What's happening? कुछ इशू हो रहा है क्या यहाँ पे? सेफ्टी, इज इट नॉट विजिबल हियर? सेफ्टी आई थिंक विजिबल नहीं है. मैक्सिमम टॉलरेबल डोज सेफ्टी. ओके, नाउ इट्स ओके आई गेस. अभी विजिबल हो गया. नाउ इट्स फाइन आई गेस. नाउ इट्स फाइन. कहीं कहीं पे कुछ प्रॉब्लम है आई गेस. आई हैव हाईलाइटेड एंड नाउ इट्स फाइन. नाउ मैक्सिमम टॉलरेबल डोज है ना 25 to 100 will be the sample size, and it's going to be an open label. Phase 2, patients are enrolled for the first time in which phase of clinical trial? That is going to be in phase 2, and mainly to determine the aim of this phase 2 will be to determine the efficacy. Now phase 2 is further divided into early phase of phase 2 and late part of phase 2. In early part, the sample size will be up to 200, and the late part it will be 200 to 400. The study design also changes. In the early part, it is going to be a single blind study. Single blind means only the patient is not aware whether he is taking active compound or placebo, and in a double blind, the patient and researcher, both of them are not aware. The drug is just coded with numbers like 1, 2, A, B, like that. Okay, so again that will be phase 2. Patients are enrolled for the very first time in phase 2. Who is the sample population again in phase 3? Remember, it is also known as your confirmatory trial, and patients are also being continued. So remember, phase 3 is a replica of phase 2. What did I say? I said phase 3 is the replica of what? Phase 2. But with a large number of population. It's a replica of phase 2 with large number of population. It will also be multi-centric trial. So mainly, since its other name is confirmatory trial, so to confirm the efficacy, of a drug, and sample size will be somewhere between 1000 to 5000. On an average, I'll be taking around 3000, and this is going to be a double blind crossover study. That means after half of the study, you are going to switch. After half of the study, you are going to switch the population. So this will be double blind crossover. At some point, I don't know, it's not visible, but I guess it will be okay now. Double blind crossover. I hope it's visible now. अभी visible है? Yes. Therapeutic dose you'll be giving in phase 2 only. Phase 2 or phase 3 दोनों में therapeutic dose देंगे. In phase 2 and phase 3, in both of them we are going to give therapeutic dose. Phase 4 is also known as your post-marketing surveillance. There is PMS, post-marketing surveillance, and mainly the aim is to know the rare or long-term ADR. To know the rare or long-term ADR, long-term adverse drug reaction. Okay, there is no limitation on the sample size, and this is also going to be an open label study. It will also be an open label study. So this was a quick summary of the important phases of the clinical trial, and definitely we'll be having one question from this one. So let's quickly see that phase 1 patients will be enrolled for the very first time. Other name of phase 3 will be your therapeutic confirmatory trial. To confirm the efficacy, we'll be using phase 3 clinical trial. Okay, to know the rare or long-term ADR, we'll be doing phase 4 clinical trial. Right, sample size you can very easily remember. Phase 1 will have around 100, 2 somewhere revolving around 200, 3 will be around 3000, 4 pay there is no limitation on the 4. Okay, there is no limitation on the phase 4 clinical trial. Okay, now another question that can be asked from all of you guys will be the sample in phase 0 or phase 5. Now can you quickly tell me that who is the sample population in phase 0? Is it animal or human? It is usually done on animal or humans. This is known as pharmacoepidemiology. Pharmacoepidemiology, है ना? And this phase 4, can you tell me it is done on animals or humans? It will be done on the normal healthy volunteers. It will be done on the normal healthy volunteers. Okay, great. Normal healthy volunteers. What is the sample size? The sample size will be around 5 to 10. As low as 5 to 10 you can take normal healthy volunteers, and it may you'll be giving a radio labeled dose will be given. This radio labeled drug dose will be given, and it is actually followed inside the body. Followed inside the body. What is the aim of the phase 0 clinical trial? The aim of the phase 0 clinical trial mainly to study the pharmacokinetic property of the drug. Right? If the drug is having high phosphorus metabolism, we will hold the trial even in the phase 0 only, just in phase 0. Remember, this is a non-mandatory trial. Pharmaceutical company is doing this to save their own time, money, resources. Okay, so this was a very quick review of important points in the clinical trial. Then we can do some more points in general pharma and ANS. Question number 1. Vasomotor reversal of Dale is elicited by. How can you elicit vasomotor reversal of Dale? The other name for this one will be your Dale's reversal phenomena. Remember, this is a topic of experimental pharmacology. Dale's reversal phenomena, that is the same thing. So how can you elicit Dale's reversal phenomena or vasomotor reversal of Dale? So for this, option will be alpha blocker followed by beta blocker followed by alpha blocker then epinephrine, है ना? Or they can give you other option like this, है ना? Atropine, acetylcholine, ऐसे करके 4 option frame करेगा very easily. Alpha blocker followed by beta blocker. Yes, I hope all of you guys will be marking that, but don't mark that. Don't choose that alpha blocker followed by beta blocker. It will be in presence of alpha blocker if high dose of epinephrine will be given. Right? No, alpha then beta, again caregiver. I said don't mark that. Yeah, because that is the most likely answer which most of the students will be choosing. I'm pretty sure in the examination. But remember, for inducing the Dale's reversal phenomena, if you're going to give high dose of epinephrine in presence of alpha blocker, so alpha blocker followed by high dose of epinephrine, this will be eliciting Dale's reversal phenomena or vasomotor reversal of Dale. And in this, the graph you will be getting a single, uniphasic response of the graph you will be getting. So if this will be the normal response, once you give this, you will be getting a uniphasic response like this, है ना? ऐसे करके आपको एक ग्राफ मिलेगा. ठीक है? So this will be only fall in the blood pressure, which will be mainly due to the beta 2 receptor. So remember, it will be uniphasic responses. The basic concept of this we have discussed in ANS in our previous classes already. Next question, examiner can ask you, okay, what about dexmedetomidine? What is the mechanism of action? Remember, dexmedetomidine में एक word जो आ रहा है, that is 2. Dexmedetomidine. I want you to remember that this is a very simple drug from the alpha 2 agonist. Question number 1. That we don't have only clonidine or alpha methyl dopa, we have many other drugs. One of which will be dexmedetomidine is alpha 2 agonist. Remember, it decreases the secretion and it also causes sedation. Because of this particular reason, it is utilized mainly as a pre-anesthetic drug. So currently very commonly utilized drug as a pre-anesthetic drug. Please do remember that even clonidine can also be used, but dexmedetomidine is specifically developed as a pre-anesthetic drug. Medetomidine alpha 2 का antagonist मत बोलिएगा, agonist. Antagonists we are not using clinically. Yohimbine is a drug from the alpha 2 antagonist. Drug of choice for cheese reaction. We will be using drugs like, what is the drug of choice for cheese reaction? The drug of choice for cheese reaction will be phentolamine. How will you elicit cheese reaction, guys? Phentolamine is actually one of the non-selective alpha blocker. If you are going to give tyramine rich food in a patient who is already on MAO inhibitor, right? How will you elicit cheese reaction? Tyramine rich food in patients on MAO inhibitor. If there will be tyramine rich food in patient those who are on the MAO inhibitor. Okay, this is how you can elicit the cheese reaction. This is how you can elicit the cheese reaction. Okay, longest acting selective. All the selective alpha 1 blocker, remember, will be having zosine in their name. Point to remember, prazosine, terazosine. The one which will be longest acting, जो दूर तक जाएगा, that will be doxazosine. दूर तक जाएगा, that will be your doxazosine. दूर तक जाने वाला zosine. It's ऐसा alpha 1 antagonist which will be lasting for the longer distance. Other drugs that we have under this one. What are the other drugs that we have under this one? We have other drugs from this class. We have drugs like your prazosine, right? Terazosine, elfusosine, bunazosine, all of them. Remember, these are considered as a drug of choice in a patient with the benign prostatic hypertension with the hypertension. Hypertensive patient with the BPH will be preferring them as a preferred agent. But if there is only BPH, patient is having only history of benign prostatic hypertrophy, we will be giving the drug of choice as a tamsulosin. Okay. They will also be preferred as a drug of choice in a patient with a scorpion bite, which was asked in the 2022 NEET PG examination. Do remember, it is having multiple other roles as well. Like for example, इसमें the drug of choice होगा. Other role, they can also be utilized in a patient with the erectile dysfunction. It can also be utilized in a patient with a peripheral vascular disease like Raynaud's phenomenon. We can use. Alpha blocker is also the same drug that was also used for eliciting vasomotor reversal of Dale. What did I say about vasomotor reversal of Dale? How will you elicit vasomotor reversal of Dale? If you are going to give a high dose of epinephrine in patient who is already on the alpha blocker. Now, which is the beta blocker that is having the antioxidant property, right? This is one of the third generation beta blocker, and it also has alpha 1 blocking property. The name is carvedilol. Carvedilol. It is also the most preferred beta blocker. It's the most preferred beta blocker in a patient with the congestive heart failure, chronic congestive heart failure. In fact, chronic congestive heart failure. What about bithanicol? It's a cholinergic drug, right? So over bladder, which receptor that we have? M3. So this is going to be an M3 agonist. Now, can you guys tell me in which scenario we can use bithanicol? If it is a cholinergic drug, then what will they do? If it is a cholinergic drug, what are they going to do? They will be increasing more and more contraction of the detrusor muscle, and therefore the urine outflow will increase. Which type of patient will get benefited through bithanicol? Again, a very simply asked question, but many of the students are getting confused, and they will be giving this in a patient with the overactive bladder. But is it possible? They themselves are increasing the urine outflow. How can you give them in the overactive bladder? So in which scenario you can use? Because they are increasing the urine outflow, they will be mainly utilized in treatment of urine retention. In the treatment of urine retention. Is it making sense to all of you? Urine retention. Bithanicol. Though it has many other uses as well, like we can also use them in xerostomia because they are M3 agonists, so they can also increase the glandular secretion. In that case scenario also we can use. Paralytic ileus, maybe we can use bithanicol because it's an M3 agonist. They can also increase the intestinal motility. A specific drug for urine retention, definitely we can use. Side effect of alpha blocker. So since I am discussing about alpha blocker, again, alpha blocker, they can definitely cause postural hypotension. That is one important side effect. Postural hypertension is one of the important side effects. What is the other side effect? Apart from causing postural hypertension, what kind of other side effect they can cause? Retrograde ejaculation, very, very important side effects. So be it any type of alpha blocker, selective, non-selective, doesn't matter, but these two side effects will definitely be there. Allopurinol, it is considered the drug of choice in a patient with the chronic gout. Remember, it is actually xanthine oxidase inhibitor. Phenytoin actually follows which order kinetic, guys? Zero order kinetics. But another question that is you should know, that phenytoin in the dose range of 10 to 20 microgram per ml, it follows actually first order, but only in the plasma concentration of beyond 20 they will be following your, they will be following your zero order. I think there is problem again. मेरे iPad में तो ठीक चल रहा है, बट आई थिंक स्क्रीन पे पता नहीं क्या प्रॉब्लम हो रहा है. Chronic gout, these are the xanthine oxidase inhibitors. Xanthine oxidase inhibitor. Okay, I hope chronic gout अब visible है. Now it's visible, I guess. Now dabigatran, again another very simple drug. Dabigatran, I have already told you. Dabigatran, they are directly acting direct thrombin inhibitor. They are the direct thrombin inhibitor. So what is the indirect thrombin inhibitor? Heparin will be indirect thrombin inhibitor because they will be increasing the activity of antithrombin 3. They are going to increase the activity of antithrombin 3. So they are the direct thrombin inhibitor, and the route of this dabigatran, it is the orally available direct thrombin inhibitor. All others direct thrombin inhibitor that we have, what are the all other direct thrombin inhibitor? Can you guys give me? Hirudine, lepirudine, bivalirudine, ergotroban, melagatan. They are the also direct thrombin inhibitor, but they are injectable agents. Okay, they are injectable agents. Anti-amoebic drug that is showing disulfiram-like reaction, it will always be seen due to inhibition of the enzyme aldehyde dehydrogenase. So the name of the drug will be your metronidazole. I think it's pretty simple. Metronidazole is the name of a drug that shows disulfiram-like reaction. So ये सारे के सारे क्वेश्चन भी पहले पूछे हुए. Most cardiotoxic, again PYQ आ गया बीच में. So that will be your anthracycline group. Anthracyclines, drugs like your doxorubicin, drugs like your daunorubicin, idarubicin, they are the cardiotoxic anti-cancer drug. Acetazolamide is a carbonic anhydrase inhibitor, and flutamide, it is one of the anti-androgenic drug. Androgen receptor antagonist. Mushroom poisoning. What is the drug of choice for mushroom poisoning, guys? What will you use for mushroom poisoning? है ना? मशरूम पॉइजनिंग में क्या यूज करेंगे? Sorry. Yes. Other students also, please take part. मशरूम पॉइजनिंग में क्या यूज करेंगे? This is one question. I cannot see your comments. Okay. Alright, so again mushroom will be containing muscarine, so definitely all of you can understand that there will be excessive secretion, there will be more and more cholinergic symptoms, there will also be bradycardia, right? So all of you are giving correct answer here, very good. Now I can see your comments. So mushroom poisoning will be using again the drug of choice will be same, that is going to be your atropine. Great. Okay, so drug of choice for this one will be your atropine. Rituximab, it is one of the anti-CD20 monoclonal antibody. Rituximab. I'll talk about rituximab in the immunomodulator chapter as well. Okay. Therapeutic index actually is a measure of what? It's actually a measure of safety. How will you calculate therapeutic index? It is actually lethal dose divided by the effective dose. Lethal dose divided by the effective dose. So the simple mnemonic for this one will be your TIL, therapeutic index is equal to lethal dose divided by the effective dose. Lethal dose divided by the effective dose in the 50% of the population. ठीक है, और experimental animals. LD50 divided by the ED50. Therapeutic index is equal to LD50 divided by the ED50. Simple mnemonic will be your TILE, T-I-L-E. Therapeutic index is equal to lethal by effective dose. Thiazide diuretics, quickly you guys can give me. Each one of them have been a part of question, guys. How will these thiazide diuretics work? Right? How will these thiazide diuretics work? They are the NaCl co-transporter inhibitor. NaCl co-transporter inhibitor. Yes. At the early part of DCT. Early part of DCT. For hyperthyroidism in third trimester pregnancy. If there is third trimester, definitely examiner can also ask you about the first trimester. Drug of choice और hyperthyroidism in third trimester pregnancy एक आध क्वेश्चन बीच में से आ गया है कहीं से. But again we can quickly do this. Hyperthyroidism third trimester और the first trimester. First trimester पहले pregnant होती है तो पहले देंगे PTU. Pregnancy में पहले देंगे what? PTU. Second और third trimester में, second and third trimester में we can actually use drugs like your methimazole. And the pro-drug of this one will also be carbimazole. So either of them we can use. Methimazole or carbimazole can be used. Can you tell me what will be the teratogenic outcome if methimazole is exposed in the first trimester, which I have already told you in the very first slide today? Methimazole, carbimazole, if it is exposed, if the patient is exposed in the first trimester, what will be the possible outcome? Can you guys tell me? The possible outcome if the person is exposed in the first trimester with the methimazole, carbimazole will be aplasia cutis. Okay, mechanism of action of micamilamine. They are actually ganglion blockers. Ganglion blocker. They are the second, third line drug in hypertension. Now, can you guys tell me? Can you tell me that any other drug that is having in ganglion blocker apart from this? अगर trimester mention ना किया हो तो go ahead with the safer drug propyl thiouracil. वो तो सब में safe है. Second, third में भी safe है. Dr. Nitin Bhatt. Can you tell me any other ganglion blocker that you know? NN blocker. Any other NN blocker? Micamilamine is a NN blocker. They can be used in hypertension. They can also be used as in a patient with the nicotine poisoning. Any other ganglion blocker? Any student? Any other student who can give me any other name of ganglion blockers? There are many drugs. I mean, they are not very commonly used, but definitely you guys should know. Option. बाकी लोगों को ट्राई करने दीजिए. I can give you some option that the name start with letter M. जैसे कि मिकामिलामीन हो गया. It's a ganglion blocker. We also call it as a NN blocker. Very good. है ना? Methonium. So remember, trimethophan, hexamethonium. Okay. Other here will be your trimethophan, hexamethonium. So these are the other, and they are also considered the antidote of nicotine poisoning. So one more point that you can take note here, that these are considered as an antidote for nicotine poisoning. Antidote for nicotine poisoning. So direct question in a case-based scenario can be given to you. A patient is presenting with the history of intake of multiple packets of e-cigarette ka history, which have been asked already in USMLE as well. And considering he is not going to get cancer, so he is taking a lot of e-cigarette. And now he is having problems like blurring of vision, high blood pressure, tachycardia, and loss of consciousness. He was brought. What is the antidote that you can use? Drug is launched in the market. I am pretty sure that you guys are already aware about this. A drug is launched in the market after which phase? So a drug is launched in the market after phase 3 of the clinical trial. Norepinephrine in a transplanted heart. Expect this question. Norepinephrine in a transplanted heart. Can you tell me? All of you guys, please take part in this one. Norepinephrine, because you are not writing. I'm pretty sure that most of you are not writing. So you take part in this one, because this is how you are going to actively participate. 3 hours के लिए मैंने आपका time मांगा था. Just 3 hours. Believe me, you will end up revising a lot of important concept here in this 3 hours. Okay. transplanted heart. Usually norepinephrine in a normal scenario, in you and me in a normal scenario, it will be leading to a condition known as a reflex bradycardia. It will be causing reflex bradycardia, but in a transplanted heart, the reflex action cannot come because the vagal tone of the heart has been transected already. So there will be only increase in the heart rate, only increase in heart rate. There will be no reflex action. Remember that. Mira background, V background कैसे काम करेगा? Mira background, V background. How are they going to work? There is one more drug, Mira background. So they can ask you, Mira background, first and foremost, it is a beta 3 agonist. Question number 1. Beta 2 agonist drugs like salbutamol, terbutaline, salmeterol, formoterol. Beta 3 agonist, Mira background, V background. Mira background, V background. Background. Now, if they are going to be Mira background, V background, acting as a beta 3 sympathetic, so we all know sympathetic will sympathize. So it will sympathize bladder as well, then they will be causing relaxation of the bladder. They will sympathize everyone, including the bladder as well, and therefore there will be relaxation of the bladder. Can you tell me if there is a relaxation of the bladder, in which type of patient we can use Mira background or V background? किस patient में use करेंगे? If there is a patient who is coming to you with the overactive bladder or incontinence, or a case of incontinence. Making sense? Methoxamine, midodrine, है ना? Which class of drug is this? Methoxamine, midodrine, mefentermine, they are the alpha 1 agonists. They can be mainly used in the treatment of postural hypotension. Right? Methoxamine, midodrine, they can be used in the treatment of postural hypotension. For the treatment of postural hypotension. Okay? Alright, oximes. So you all know we have pralidoxim, and we also have obidoxim. Now, why am I writing in two lines, pralidoxim, obidoxim, and then we also have one more, diacetyl monoxime. So we call this one as a DAM, simple DAM, diacetyl monoxime. So they will be acting PO peripherally only. Pralidoxim, obidoxim, they are going to act peripherally acting. Pralidoxim ko we also write it as a PAM. So their site of action will be peripherally only. Diacetyl, di means 2. या D से 2 याद कर लो. So they will have peripheral plus central action both. Peripheral plus central action both will be seen with the diacetyl monoxime. What about edrophonium? Edrophonium is available in the market by the name of tensilon. Therefore, it is also used for a test known as a tensilon test. Two questions have been asked here. What is the mechanism of action? So mechanism of action, it's a reversible acetylcholine esterase inhibitor. That's a mechanism of action. And what is the use? That's the second question. So it can be used to differentiate between myasthenia gravis and cholinergic crisis. So which of the following drug will be utilized to differentiate between myasthenia gravis and cholinergic crisis? Or which of the following drug is used in tensilon test? Again, the answer for all of them will be edrophonium. It's a reversible acetylcholine esterase inhibitor. They are shorter acting agents. We definitely can use in this scenario. Which anti-asthmatic drug avoided with the erythromycin? Always remember, ये जो 4 क्वेश्चन इस स्लाइड पे मैं दिया हूँ, this 4 क्वेश्चन are from drug interaction. Expect one question from drug interaction. Definite one question from drug interaction. Okay. Now, which anti-asthmatic drug is a very narrow therapeutic index? Theophylline. And why it is avoided with erythromycin, clarithromycin? Because this is a case of enzyme inhibitor. Okay, enzyme inhibitor. Always remember. So the name of this anti-asthmatic drug will be theophylline. Very good. Now, what is the interaction of warfarin with clarithromycin? Isn't that clarithromycin is also coming from the same family? Clarithromycin is also coming from the same family, that is enzyme inhibitor, and therefore warfarin will do what? Warfarin, again anticoagulant. If it is given with the enzyme inhibitor, they will always increase the risk of toxicity. They will increase the risk of toxicity, and therefore bleeding risk will increase. Bleeding risk is going to be increased. So again, PTINR level will be highly deranged. So normal 2 to 3 के बजाय there will be 6, 7, 8 any other PTINR level will be there. Okay. Now, what about rifampicin? It's a very potent enzyme inducer, and therefore rifampicin will always cause your treatment failure. They always cause what? Treatment failure. And therefore, if a person who is on OCP and she contracted, let's say, TB and she is on rifampicin, it is always advised to take an alternative modality of contraception. Okay, remember that, because rifampicin is an enzyme inducer. So in the examination, although we are discussing it here and all of you guys will say thumbs up and all of you guys will say yes, I understood, but in the examination when it is asked, one definite question from the interaction and most of the students mess up during the examination. Remember, simple story. Whenever examination is near, let's say examination is just 2 days away and you're continuously getting induced, let's say by your friend or girlfriend or whosoever, you can do some imagination. If you're continuously getting induced, right, let's go, getting continuously induced, तो क्या होगा? एग्जाम पास है, क्या करोगे? अवॉइड करना है, लेकिन इतने सख्त तो हो नहीं आप, मैंने बताया भी था क्लास में कि उसके लिए सख्ती जरूरी है, उतने सख्त आप है नहीं, है ना. So when you are continuously getting induced and if you are getting induced as well, then there will be higher risk of failure. There will be higher risk of what? Failure. बार बार induced नहीं होना है, failure का risk ज़्यादा होगा. Another thing is that if you are getting inhibited, मान लीजिए आप खुद चाहते हैं, but if you are making a move, आज नहीं कल, not today, we cannot go for shopping today, we cannot go for movie today, no date today, continuously getting inhibited, बार बार आपको inhibition मिल रहा है, तो क्या होगा? आपके अंदर टॉक्सिसिटी भरती जाएगी एंड वन डे वो डेफिनेटली फटेगा, डेफिनेटली वन डे यू विल बर्स्ट, यू विल ब्लास्ट, है ना. ऑलवेज रिमेंबर, इफ यू आर कंटिन्यूसली बीइंग इनहिबिटेड, व्हाट विल हैपन? देयर विल बी इंक्रीज इन द रिस्क ऑफ टॉक्सिसिटी. व्हाट डिड आई से? अगर इनहिबिट हो गए तो टॉक्सिसिटी होगा एंड इफ यू आर कंटिन्यूसली गेटिंग इंड्यूस्ड, फेलियर का रिस्क ज्यादा रहेगा. प्लीज डोंट फॉरगेट दिस स्टोरी इन द एग्जाम एंड जस्ट मार्क इट. इंड्यूस, फेल हो जाओगे, ठीक है. इनहिबिटेड, टॉक्सिक हो जाओगे. तो इसलिए बच के रहना, थोड़ी सख्ती में रहना है. इंटरेक्शन ऑफ एंटासिड एंड टेट्रासाइक्लिन, सो दे कैन गिव यू टेट्रासाइक्लिन, दे कैन गिव यू ड्रग्स लाइक योर ACE inhibitor, they can give you drugs like your thyroxine. I hope you will not make mistake in this one. Enzyme inducer, enzyme inhibitor, done. I'll give you the list of as well. There is a list of enzyme inducer, enzyme inhibitor as well, which I'll be giving you subsequently. Okay. Now, what will antacid do here? Antacid, they are always going to interfere with the absorption of these drugs like tetracycline. So the antacids are going to interfere with the absorption, inhibit the or interfere with the absorption, because they have aluminium, they have magnesium, right? They will chelate this compound like tetracycline and they will interfere with the absorption. Again, if there is interference with the absorption, the effect of tetracycline, the effect of thyroxine, the effect of ACE inhibitor will not come, right? It will not come. I hope all of you guys are okay here. And these two questions are going to be asked, that if you are getting induced, what will be the outcome? If you are getting inhibited, what will be the outcome? So remember that getting induced in the enzyme inducers. What are the enzyme inducers that we have? That GPRS, cell phone use करने से your battery becomes dead. GPRS, cell phone use करने से your battery become dead. Okay, cell phone. तो induce हो जाओगे तो your battery become dead. PH से phone, phenobarbital, your battery again another barbiturates and dead will be DDT. Again inducers will lead to what? They will increase the risk of ट्रीटमेंट फेलियर. इंड्यूस हो जाओगे तो ट्रीटमेंट फेलियर का रिस्क ज्यादा होगा. एंड देन इनहिबिटर दैट आई टोल्ड यू, अ वेरी सिंपल निमोनिक, रिमेंबर, पिकॉक वाला आएगा, इनहिबिट करके जाएगा, पिकॉक वाला, है ना. सो पी से एक वेरी इंपॉर्टेंट ड्रग विच आई वांट ऑल ऑफ यू गाइस टू रिमेंबर, दैट इज प्रोटीएज इनहिबिटर, HIV protease inhibitor. All the HIV protease inhibitor, they are ending with navir drug. They are ending with what? Navir, है ना, like indinavir, है ना, ritonavir, atazanavir, all of them are HIV protease inhibitor. Protease inhibitor, erythromycin, allopurinol, ciprofloxacin, omeprazole, cimetidine, है ना, ketoconazole, valproate. So do remember, enzyme inhibitors, they will increase the risk of toxicity. Enzyme inhibitor, they will be increasing the risk of toxicity. ये टॉक्सिसिटी के रिस्क को बढ़ा देंगे. सो डोंट फॉरगेट दिस वन. एंजाइम इंड्यूसर, एंजाइम इनहिबिटर, डेफिनेट वन क्वेश्चन यू विल बी सीइंग इन योर एग्जामिनेशन. ओके, नाउ एक ड्रग ऑफ चॉइस, केस बेस्ड सिनारियो, अगेन इमरजेंसी इज इन सेल्फ इज अ वेरी सेपरेट टॉपिक एंड वन क्वेश्चन यू कैन अगेन रिमेंबर. एनाफाइलेक्टिक शॉक, बार बार क्वेश्चन आता है, A case-based scenario, a patient is presented in emergency with breathing difficulty, with displaced blood pressure after intake of or after a bee sting or after intake of a penicillin. ऐसे करके एक केस पे सिनारी देगा and they will definitely talk about, they'll give you very simple line that okay, there is going to be anaphylactic shock. Remember, in my regular classes also I have told you that in the examination more or less around 50 to 60% question are going to be such that an average student can do. Simple, अगर आपने 4-5 घंटे डेली पढ़ाई की है, so 50 to 60 question are going to be a very simple one, and उसमें बहुत ज़्यादा दिमाग मत लगा देना, otherwise you will make mistake in that. ठीक है, बहुत आसानी से you read the question and you will realize in the exam ये भी पूछना था क्या, why did they even ask, ये तो बड़ा आसान है ना. बट अगेन अवॉइड द सिली मिस्टेक. एट द सेम टाइम आई एम गिविंग यू अ वार्निंग एज वेल, है ना, कि जब भी कभी ऐसा लगे कि ये बहुत आसान है, प्लीज रीड द क्वेश्चन अगेन. हो सकता है उसमें कुछ ट्रिक हो जो आप नहीं समझ पा रहे हैं और आपको लग रहा हो कि नहीं ये बड़ा आसान है. तो जस्ट सम टाइम कीप वेरी क्लोज ऑब्जर्वेशन ऑन दिस काइंड ऑफ क्वेश्चन. Rest, the very difficult one, which most of the students are having difficulty, are going to be 20-25% question, which have been, which we have been seen in the past. 20-25% question जो होते हैं वो थोड़े difficult होते हैं, for which we need to see the reference and all. But again, if you look at 60% and 20% are the difficult one, बीच में क्या आ जाता है, another 25 to 30%. Remember, so this 30% will be more than average बच्चे भी कर लेते हैं. So that's why the chances for you to get a score closer to 200 or 200 plus are much higher. If you are considering yourself a very average student, expect a score somewhere around 70 to 170 to 180, and believe me, you will not regret this. Just stop this fear वाला जो concept है ना, हटा दो. You have done your best, you have studied already, and then you have been studying, right? You're not going to any party and you're not going to any other time wastage वाला spot पे तो नहीं जा रहे. All of you guys are studying and there is nothing more you could have done. I believe जितना करना था you have given your best if you have done it. However, if you are one of the students, those who have let's say passed just recently, or you came to India just recently, you've not read, I mean, I'm not talking about those students, but anyway, all those students, those who have been reading from past 3 to 4 months, believe me, you will have a decent score. Just go with the confidence that yes, you have done. और एक और बात मैं बता रहा हूँ, if you have read the thing, if you have passed some of the concepts, some of the topics in front of your eyes, अगर आपके आंखों के सामने से वो नोट्स, वो टॉपिक, वो पेज गुजरा है, वो आपको रिकॉल हो जाएगा, डेफिनेटली एग्जाम में रिकॉल हो जाएगा. जस्ट डोंट पैनिक नाउ, है ना. दिस इज द डेफिनेट टाइम. मैं समझ सकता हूँ, आई कैन टोटली अंडरस्टैंड, आई कैन टोटली फील कि आप सबको कैसा फील हो रहा होगा. बट एज ऑफ नाउ जस्ट आई एम टेलिंग यू, जस्ट हैव फेथ दैट यू हैव डन योर बेस्ट. अटेंडिंग द लास्ट 3 hours, देखिए आप खुद से रिवाइज करने जाओगे 3 घंटे फार्मा रिवाइज नहीं होगा. बट मैं बोल रहा हूँ, मैं 3 घंटे में आपको रिवाइज करके दे रहा हूँ. मेरे साथ बैठो, ऑलमोस्ट 1 घंटे से ज्यादा बीत गया है, एक उतना ही टाइम और लगेगा, एंड वी विल एंड अप रिवाइजिंग द रेस्ट ऑफ द इंपॉर्टेंट कॉन्सेप्ट एज वेल. ओके, ऑलराइट. सो बस अपने आप पे फेथ रखो और कुछ नहीं यार, बाकी छोड़ दो, है ना. सोशल मीडिया पे, टेलीग्राम पे और इंस्टाग्राम यूनिवर्सिटी के क्वेश्चन छोड़ दो, अभी छोड़ दो, है ना. अब करना बंद कर दो, क्वेश्चंस जो डिफिकल्ट आते थे करना बंद कर दो. सबको पता है यार, एपिड्यूरल ब्लीड कैसा होता है, सब ड्यूरल हेमाटोमा कैसा होता है, कौन सी आर्टरी डैमेज होती है, वही क्वेश्चन आते हैं बार बार, है ना. उसी का इमेज दे देगा, पैरेनकाइमल ब्लीड होगा, हिस्ट्री दे देगा पेशेंट विद हाइपरटेंशन, है ना, और उसमें दे देगा कि ब्लीड हो गया, है ना. पैरेनकाइमल ब्लीड दिखाएगा, पूछेगा व्हाट इज द ड्रग ऑफ चॉइस, आईवी निकार्डिपिन इज द ड्रग ऑफ चॉइस, है ना. तो अगर हाइपरटेंसिव इमरजेंसी हो गया, एंसेफेलोपैथी हो गया, एंड ऑर्गन डैमेज हो गया, हाइपरटेंसिव इमरजेंसी, सिमिलर काइंड ऑफ क्वेश्चन. शॉक वाला पेशेंट आता है बार बार, है ना. पेशेंट इज प्रेजेंटिंग विद हिस्ट्री ऑफ शॉक, what will you give? So, है ना, intramuscular 1:1000. So what is 1:1000? How much you'll be giving? Again, you are going to give 0.5 ml, है ना, 0.5 ml 1:1000. Also, circle of Willis वाला क्वेश्चन बार बार आता है ना. सर्किल ऑफ विलिस कब रप्चर होता है? सो यूजुअली whenever there is a subarachnoid hemorrhage, thunderclap headache वाला हिस्ट्री आएगा. द पेशेंट इज प्रेजेंटिंग विद द वर्स्ट काइंड ऑफ हेडेक, एंड एग्जामिनेशन में आपको ना कुछ स्टारी शेप दिखेगा, उसमें ब्लीड पॉइंट दिखेगा, विच ऑफ द फॉलोइंग इज द मोस्ट लाइकली डायग्नोसिस, है ना. तो बार बार ये क्वेश्चन आते रहते हैं और इससे ज्यादा एग्जामिनर के पास कुछ है नहीं. तो जो भी आपके पिछले 5-7 साल में अपने टॉपिक रिपीट किए हैं, बिलीव मी यू गाइस विल बी acing very nicely in the examination. IV labetalol can be used, definitely you can use, है ना. Definitely you can use IV labetalol as well. इसमें कोई डाउट नहीं कि आप नहीं यूज कर सकते. Okay. चलिए, so epinephrine intramuscular route 1:1000 0.5 ml you will be giving. Okay, then again another question that we have, if the patient is coming to you with shock with oliguria, we will be giving dopamine in the dose of more than 10. But can we use dopamine in a patient with the acute heart failure? Can you guys tell me that can I use dopamine in the acute heart failure? Dopamine in acute heart failure? Yes, we can use dopamine in acute heart failure. The dose should be 2 to 10 microgram per kg per minute. 2 to 10 microgram per kg per minute. Okay. Shock without oliguria, we can use because in a dose of 2 to 10 microgram we will be stimulating your beta 1 receptor. Okay, so inotropic support के लिए हम दे सकते हैं. ठीक है. Without oliguria में we are going to use dobutamine. Dobutamine, it's the selective beta 1 agonist. In fact, this dobutamine, it is also considered the drug of choice in a patient with a cardiogenic shock, and it is also considered the drug of choice in a patient with the acute heart failure. Acute heart failure maybe also it's a preferred drug. Vasovagal shock maybe we are going to use drug that is atropine. Neurogenic shock, so sometimes they can give you history a patient on the anesthesia table, है ना? So there will be decrease in the sympathetic tone. So sometimes there can be history of anesthesia. है ना, एनेस्थीसिया का हिस्ट्री आ सकता है इसके साथ. एंड ड्रग ऑफ चॉइस फॉर दैट विल बी योर phenylephrine, a selective alpha 1 agonist. Septic shock, again this is the only type of shock where the heart rate will be high, body temperature will be high, so we are going to use norepinephrine as the drug of choice in a patient with a septic shock. Dobutamine, as I said, it's the drug of choice also in a patient with the acute heart failure. Acute heart failure will be also, they are the drug of choice. Okay. Alright, so we are done with these two topics. I believe all of you guys have actually seen this already. Okay, great. Now one more question that is very frequently asked. I think there is some disconnection. System support नहीं कर रहा है आज, कुछ ना कुछ प्रॉब्लम हो रहा है. Alright, so we are back online. Okay, so drugs that are following zero order kinetics, always remember the drugs those who are following zero order kinetic, they will be problematic only at the higher doses. In the lesser doses, in the low doses, they are not going to be so problematic. They will be following first order only, but in the higher doses, they will be following zero order kinetics. So remember, these drugs are remembered by the very simple mnemonic that getting zero in an examination is like a war, and only you can put an end to this war. So I'll tell you, you put an end to this war. You put an end to this war. So that will be unfractionated heparin. Right? This unfractionated heparin will be same as the usual heparin, because your low molecular weight heparin, please do remember, it follows first order. The rest all other drugs follows first order kinetic. Zero order kinetics are problematic. They keep on accumulating at the high doses and they can cause problem. They can cause toxicity. Okay. Aspirin, ethanol. Ethanol, in fact, one more question. This is the only one that follows true zero order kinetics. This is the only one that follows true zero order kinetics. The rest all follow pseudo zero order. What is the meaning of pseudo zero order? Initially they will be following first order at the lesser dosage, and at the high dose they start following zero order kinetics. Tolbutamide, theophylline, warfarin. So what about heparin and warfarin? Remember, they both can follow zero order kinetics. Now one more question that is asked from the types of receptors. In the receptor, one of the question that is frequently being repeated is from the G protein coupled receptor. What's the name? The name is your G protein coupled receptor, GPCR. This is the most commonly utilized receptor by majority of the drugs. Most commonly utilized receptor by the majority of the drugs. So majority of the drugs will be acting by G protein coupled receptor. Okay, G protein coupled receptor, and there are three types. इसका जो अल्फा होता है, अल्फा इज द एक्टिव कंपोनेंट ऑफ द जी प्रोटीन कपल रिसेप्टर, एंड दिस अल्फा इज फर्दर सबडिवाइडेड इनटू थ्री इंपॉर्टेंट एरिया, GS, GI and GQ. So how do they work? GS, again remember, they will be acting by stimulating adenylyl cyclase, therefore ATP breakdown to CAMP will be increased. CAMP is going to act as a secondary messenger, and a lot of receptor will be acting via this GS. So examiner will not be giving you the word GS. Examiner क्या देगा? Which of the following is going to act by increasing the adenylyl cyclase activity? adenylyl cyclase activity. Again, you are increasing adenylyl cyclase with the GS. So example of receptor will be BDSH, that is beta receptor, all the beta 1 to 3, dopamine 1, 5-HT4 and histamine, right? BDSH, don't forget. Then we have GI, which is going to act via inhibiting ATP conversion to CAMP. That will be done by inhibiting adenylyl cyclase. So ATP breakdown to CAMP will be decreased. One more mechanism of action that has been said for GI, that the beta and gamma component of GI, the beta and gamma component of GI, they are going to open the acetylcholine sensitive potassium channel. Please remember, they are going to open acetylcholine sensitive potassium channel. Because they open acetylcholine sensitive potassium channel, they will be causing potassium ka efflux. Boys and girls, you can easily understand, if there is an efflux of potassium, what will happen? There will be hyperpolarization. Very easy to remember. So GI mean two important things. One is definitely they are going to inhibit adenylyl cyclase, and second one, the beta and gamma component, they are going to open the acetylcholine sensitive potassium channel. And always remember, whenever potassium channel is open, there will always and always be efflux of the potassium leading to hyperpolarization. In example of receptor through for GI will be alpha 2, dopamine 2. 2 is a favorite word, not with all but with maximum. And alpha 2, dopamine 2, opioid receptor M2, M4, 5-HT1, H3 and H4 as well. H3 and H4. H3 and H4 as well, they will be acting via GI. So पहला मैंने क्या बोला, ADOMS, पहला बोला BDSH बादशाह, and next I am telling you ADOMS, alpha 2, dopamine 2, because dopamine 1 is acting as GS, opioid receptor M2, M4, 5-HT1 and H3 and H4. Okay, so ADOMS, so बादशाह ADOMS. Then GQ वाला क्वेश्चन कैसे पूछा है, which of the following is going to act via activating phospholipase C, or they can also ask a question like the one that is acting by increasing IP3 or DAG. So by increasing the IP3 and DAG pathway, they will be causing calcium influx. An example of receptor that is acting through GQ will be your M1, M3, M5, alpha 1, AT1, your TSH, H1, and also your 5-HT2. 5-HT2. So serotonin का 2, serotonin का 2 नंबर वाला will be acting via GQ. Serotonin का 1 नंबर वाला कहाँ से काम करेगा, 5-HT1. Again they are the 5-HT1 GI है ना, auto receptor. So you can remember M, M1, M3, M5, all the odd numbers. Alpha 1, most of them are having one word here. Alpha 1, AT1, TSH, H1 and 5-HT2. So a whole story here says that there is a बादशाह जिसका नाम था ADOMS. So बादशाह ADOMS का maths is a questionable. बादशाह ADOMS का maths is questionable. Why questionable? Because GQ maths will be GQ. बादशाह ADOMS का maths is questionable. Okay, so let's repeat. Maths M1, M3, M5, alpha 1, AT1, H1. Okay, TSH, 5-2. Badshaw Adams ka maths is questionable. Then on the basis of graph also they ask you 2-3 questions. One will be this one. I think all of you guys are already aware. The one that is producing maximal intrinsic activity will be agonist, and the intrinsic activity score will be your +1. This will be IA score. Intrinsic activity score will be +1. Next one will be the one that is producing submaximal intrinsic activity will be partial agonist. Antagonists will have no intrinsic activity. They will simply occupy the site and they will not do any action. The very good example of flumazenil will be antagonist or antidote also for benzodiazepine. Then inverse agonist will be acting via the negative action, opposite action. So drug after binding with the receptor will be producing opposite action. A very good example will be beta carbolin. It's the inverse agonist for benzodiazepine. It's the inverse agonist for the benzodiazepine. So they will be having opposite action. I am pretty sure that all of you guys will take note of this graph, and remember the same graph was also asked in the one of the recent examination that we had. Okay. Then you can also see a graph on the basis of this this one. This is one graph. The true statement about the shown image. Can you tell me what is the true statement about the shown image? Anyone? Quickly. About the potency and efficacy. You have to identify the potency and efficacy. है ना। चलिए मैं दो ग्राफ आपके सामने ड्रॉ करूंगा। ओके लेट्स से आई एम गिविंग 3, है ना, 3 ड्रग्स हियर। इसका नाम मैं रख दे रहा हूं फिर से अगेन, ए बी सी। कैन यू टेल मी द ऑर्डर ऑफ पोटेंसी हियर? फटाफट बता दो ऑर्डर ऑफ पोटेंसी फॉर द फर्स्ट इमेज। ऑर्डर ऑफ पोटेंसी, potency, P for potency, P for power, we always look at what? The left wala will be most powerful, so potency will always go in this order, right? Left to right, as you move, the potency will decrease. So potency here will be A followed by B followed by C, A B followed by C. I think it's pretty simple. Then if the examiner is going to ask you about efficacy, can you tell me about the efficacy? Potency, P for potency, P for power. Don't make mistake in that. Efficacy, I always used to tell you that always remember Eiffel Tower. Efficacy से क्या याद करना है आपको? Eiffel Tower. And why is Eiffel Tower very very famous? Eiffel Tower is famous because of its what? Its height, है ना? So efficacy क्या होगा? B is equi efficacious to C because दोनों का height almost same है अगर देखेंगे तो C. B is equi efficacious to C and least efficacious will be A. Pretty simple, right? Potency, as you move from left to right, the potency will decrease. The height decrement will be your efficacy. Now it's second वाला, again एक और exercise कर लेते हैं. For this one again, can you tell me? This is let's say log dose, and this is the response. This is the response, log dose and response. Please tell me the potency for this one. Potency for this one, it will go always in the same way, है ना। मैंने जो बता दिया रूल वही रहेगा। Potency, power, always look at the dose वाला line, है ना। PDL was the mnemonic that I told you in the class as well. Potency में look at the dose line, left वाला will be most powerful, left वाला will be the most potent, and you move from left to right, potency will decrease. So here also the potency will go A, B followed by C, ठीक है। What about efficacy? Efficacy बताइए। Efficacy, Eiffel Tower. So which is the most potent? Again, A is the most efficacious as well. A is the most potent as well. What about the next? Next one is going to be your C followed by B. Now I'll be giving you one statement for image number B. Second image के लिए मैं आपको statement दूंगा and then you have to tell me true or false. All of you be ready. I'll be giving you a scenario. You have to tell me true and false, and you can expect a definite question from the image based scenario from here. Okay. Drug A is most potent and most efficacious. Is it true or false? In the second image, in this image, drug A is most potent and most efficacious. True or false? Go ahead please, fast. Just write T or F. Dr. Vikram is saying false. नहीं, क्वेश्चन सुनिए। A is most potent and most efficacious. इट्स ट्रू, डेफिनेटली। इसका हाइट भी बड़ा है एंड सबसे लेफ्ट में भी है। पोटेंसी क्या होगा? सबसे लेफ्ट टू राइट। आईफिल टावर एफिकेसी, हाइट देखना है, ठीक है। ए इज मोस्ट पोटेंट एंड मोस्ट एफिकेसियस, ठीक है। ओके, नेक्स्ट स्टेटमेंट बोल रहा हूं, ध्यान से सुनिएगा। सी इज लीस्ट पोटेंट एंड लीस्ट एफिकेशियस। सी इज लीस्ट पोटेंट एंड लीस्ट एफिकेशियस। ट्रू और फॉल्स? Drug C is least potent and least efficacious. Gayatri is telling true. Okay. Other students are telling false. Drug C is least potent and least efficacious. It is definitely false. It is least potent, yes. But is it least efficacious? No. उससे भी छोटा एक ग्राफ है B वाला. B is the least efficacious. See, यहाँ पे आपने लिखा ना efficacy B का सबसे कम है. Right? Okay, great. Now on the basis of that, please mark the question that is given here. This is for this image that is given, image number 1. A is least potent, most effective. A is more potent than B and more effective than C. B is more potent than C and A. C is least potent and more effective than A. Please go ahead. A, B, C, D बताइए. What is the correct answer for this one? A, B, C बताइए. Which is the true statement about this question? Okay, great. So the only one which is a true statement is option number D. Drug C is least potent, yes, and more effective than A, yes. Other option A is least potent, yes. Is it most effective? No, it's not most effective. In fact, it's the least effective. Okay. Option B, drug A is more potent than B. So A is more potent than B, yes, half of the statement is correct. And more effective than C, again, other half of the statement is wrong. Okay. Option C, B is more potent than C and A. Undoubtedly, B is more potent than C, but it is not more potent than A. A question from autocoids. Always remember, autocoids में एक question आपको कभी भी आ सकता है. And in autocoids, what are the things that you are going to always recall and remember? That one thing that is your histamine, and other thing that I want you to remember will be your serotonin. Question number 1. That histamine के कितने receptor हैं? Histamine will be acting via receptors like your H1, H2, H3 and H4. This is what the drugs that we have: H1, H2, H3 and H4. Histamine के. What is the associated receptor through which they are going to work? Associated receptor, which of the following is going to act via GS among the following? H2 is the only one that is going to act via GS. H2 is the only one that will be acting via GS. What about H3 and H4? H3 and H4, their activity is mediated by GI. We are left only with the H1. We are left only and only with the H1, and H1 activity is mediated by GQ. I told you most of the H1 wala will be acting through GQ. Now they are mainly involved in the inflammation, right? Allergy. And always remember, whenever we give H1 antagonist, like for example your chlorpheniramine, they are mainly utilized in which scenario? Allergy. We are mainly using chlorpheniramine in which scenario? Sorry about this. We'll write it again. I believe there is some problem here. H1 antagonist will be known as your chlorpheniramine. Why is it coming like this? Okay, sorry about that. Again, let's start. H1, the activity of H1 is mediated by GQ. Okay, and we have H1 antagonist, drugs like your, let's say, chlorpheniramine. Chlorpheniramine is the name of a drug that is going to be mediated via the activity of GQ will be H1 will be mediated by GQ, and the drug will be your chlorpheniramine, mainly utilized in allergy. We have many other drugs in this one, like for example drugs like your cetirizine, that is the second generation H1 antagonist, cetirizine. Then we also have levocetirizine. We also fexofenadine, right? These are the H1 antagonists, fexofenadine. Okay, fexofenadine is an isomer of actually terfenadine. Terfenadine is banned because of QT prolongation. Remember that. Okay. Out of them, fexofenadine, it is overall least sedative H1 antagonist, least sedative overall. But if you talk about chlorpheniramine, it is coming from the first generation, and from the first generation, it is the least sedative. From the first generation, is the least sedative. Chlorpheniramine, chota acting, will be least sedative. Remember that, chlorpheniramine. Okay. Now, since H1, histamine 1 is mainly present in the brain as well, and they maintain the wakefulness, can you tell me one important side effect associated with them? They will be associated with one important side effect known as sedation. This is one common side effect. They will be utilized in allergy, but one common side effect will be sedation. Why? Because histamine is maintaining the wakefulness. By acting through reticular activating system, they will be maintaining the wakefulness, and when you block this, there will be sedation. H2 is mainly present on the gastric parietal cell, and they are involved in the acid release, right? And we are going to use H2 blocker drugs like your ranitidine, nizatidine, loxatidine, है ना? Ranitidine, nizatidine, loxatidine. These are the drugs that we have that are coming under H2 blockers. Ranitidine, nizatidine. Then do remember, we have one more drug in this one, जिसकी cimetidine, which is very famous for two important reasons. What are the two important reasons for which it is very, very famous? One reason for which it is very, very famous is it's a very, very potent enzyme inhibitor, and because of its a potent enzyme inhibiting capacity, it is having lots and lots of drug interaction, and it is also associated with the gift of gynecomastia. Okay, two important reasons for cimetidine. We are not using it clinically. H3 is mainly an autoreceptor. In fact, H3 and H4 both are present presynaptically. They are autoreceptor. When we give H3 agonist, what will be the outcome, guys? Anyone can give me an idea? If we give H3 agonist, there will be decrease in the histamine release, because whenever autoreceptor is getting stimulated, they will always and always self-inhibit their release. They will inhibit the release of histamine. Therefore, we are going to use H3 ka inverse agonist. H3 ka inverse agonist. The name of the drug is your tiprolisant and pitolisant. Tiprolisant as pitolisant. Very good, Dr. Gohil. Yeah, definitely it's like alpha 2. Tiprolisant, pitolisant. So these are what? These are H3 ka inverse agonist. So inverse agonist means they will be producing opposite action. Yes or no? H3 again, it is causing sedation. H3, if it is present in the CNS, they will be causing sedation. And when we give inverse agonist, they will be causing wakefulness. They will be increasing what? Wakefulness. Therefore, in which type of patient you will be using them? They will be utilized in mainly in a patient with a narcolepsy. So do remember, inverse agonist ka ek aur example, that is your tiprolisant, pitolisant, they will be utilized in the narcolepsy. However, the drug of choice for narcolepsy will be modafinil. Okay? H1, H2, H3. H4 ke against we do not have any drug. We don't have any drug. The only thing that is we are aware about them, that they are present on the WBC and they are involved in the chemotaxis. Okay? Chemotaxis. H1, H2, H3 we have quickly seen. Now it's time for us to quickly also talk about your serotonin. There is no space here, so I'll talk about serotonin down here. How many receptors are there for serotonin, guys? For serotonin also, how many receptors are there? Can you tell me? That is 5-HT. How many receptors are there? Important, जिसके against drug है हमारे पास 5-HT1. We also have drugs like against 5-HT2, 5-HT3, and we also have 5-HT4. Quickly, can we revise? Again, as I said, histamine serotonin से एक question definite आप देखिएगा, आपके एग्जाम में रहेगा. Their associated G protein. Which of the following serotonin receptor does not act as G protein coupled receptor? Because 5-HT3, remember, they will be acting as your ion channel. They are actually mediated by ion channel or ligand gated receptor. 5-HT4 is the only one who is actually mediated by GS. 5-HT2 GQ and 5-HT1 they are actually mediated by GI. एक question done हो गया. We have 7 but we don't have drug against all. We have 7 but we do not have drug against all. सबके against हमारे पास drugs नहीं है. ठीक है? This is going to be ion channel receptor. 5-HT2 will be your GQ and 5-HT1 will be your GI. That means they are autoreceptors. And what are the drugs that we have? For remembering the drugs, I'll tell you a simple trick. Always remember the rule of 5. What does the rule of 5 says in the serotonin? What does the rule of 5 says? दैट ऑलवेज रिमेंबर रिसेप्टर नंबर 1 एंड रिसेप्टर नंबर 4 का हम एगोनिस्ट यूज करेंगे, विल बी यूजिंग एगोनिस्ट. रिसेप्टर नंबर 2 एंड रिसेप्टर नंबर 3 का विल बी यूजिंग एंटागोनिस्ट. सो इफ एवर यू फॉरगेट इन द सेरोटोनिन किसका एगोनिस्ट किसका एंटागोनिस्ट, डू रिमेंबर दैट पहले हम एगोनिस्ट यूज करेंगे. फर्स्ट एंड फॉरमोस्ट वी आर गोइंग टू यूज व्हाट, एगोनिस्ट. पहले हम एगोनिस्ट यूज करेंगे एंड देन विल बी यूजिंग द एंटागोनिस्ट. सो 1 एंड 4 का क्या यूज करना है, एगोनिस्ट फॉलोड बाय योर एंटागोनिस्ट. ठीक है. सो 1 एंड 4 का एगोनिस्ट अगेन 1 हो गया. सो वी हैव वेरी क्विकली आई विल बी रिवाइजिंग दिस एंड यू विल नॉट फॉरगेट. 1 का एगोनिस्ट यूज करना है. सो वी हैव 5ST 1A एगोनिस्ट एंड वी हैव 5ST 1B by D. So what are the drugs that we have? 5ST 1A में वी हैव ड्रग्स लाइक योर ब्यूस्पिरॉन, जो रोने वालों को देते हैं. कौन रोता है, जो एंग्जाइटी में. सो दे विल बी यूटिलाइज मेनली इन द ट्रीटमेंट ऑफ एंग्जाइटी. क्वेश्चन, एक क्वेश्चन ये हो गया ब्यूस्पिरॉन. देन रिमेंबर फ्रॉम द सेम टॉपिक, buspirone, it will be utilized mainly in the anxiety. There is one more drug here that is known as your flibanserin. ये कैसा ड्रग है, ये फीमेल के लिबिडो को इंक्रीज करने वाला ड्रग है फ्लिबांसेरिन. इट विल बी मेनली यूटिलाइज इन द हाइपोएक्टिव सेक्सुअल डिजायर इन फीमेल. हाइपोएक्टिव sexual desire in female. It has dual role. One of the role will be 5ST1A agonist and 5ST2 का antagonist. 5ST1A agonist and 5ST2 का antagonist. ठीक है. Hypoactive sexual desire in female. Okay. 5ST1B by D, which drug will be acting at the 1B by D? Again, B by D agonist. 1 का हमेशा हम क्या यूज करेंगे, agonist. I told you rule of 5. So remember your triptans. Triptans are going to be drug of choice in a patient with the migraine. In a patient with the acute migraine, we will be preferring NSAIDs, or acute severe migraine and non-responsive to NSAID, we can use triptans. है ना, rizatriptan, sumatriptan, naratriptan, है ना. 5ST2 we can use against 5ST2, like for example 5ST2A, है ना. 5ST2 और 3 का क्या यूज करना, एंटागनिस्ट. सो वी कैन यूज एंटीसाइकोटिक्स. प्रेफरेबली इट विल बी कमिंग अंडर द atypical antipsychotics. AT I am writing atypical antipsychotics. That is your 5ST2 का antagonist, right? We have drugs like your risky drug by the name of risperidone. Please don't forget this risky drug by the name of risperidone. We have many other drugs like your quetiapine, है ना, risperidone, quetiapine, है ना. Then we are also having other drugs like your olanzapine, clozapine. These are all antipsychotic drug, atypical वाला. Olanzapine, clozapine, all of them. Then we are having 5HT3 का antagonist. So what are the drugs? Always remember 5HT3 पे it is mainly present at the chemoreceptor trigger zone, and whenever they are stimulated they cause nausea and vomiting. So we will be using 5HT3 का antagonist. 5HT3 का क्या यूज करना है? Again antagonist. 2 and 3 का antagonist. Okay. So we have drugs like your ondansetron, granisetron, pelanosetron. We all know this one. They are the drug of choice in any patient of nausea and vomiting. Not only that, these are also considered the drug of choice for prophylaxis of chemo-induced nausea and vomiting. Chemo-induced nausea and vomiting. Okay? Chemo-induced nausea and vomiting will be also, they are going to be a preferred agent. Then we are also going to talk about 5HT4, one very important drug that you should know, which I want all of you guys to remember. We are going to use 5HT4 का agonist, है ना? 5HT4 का agonist, as I told you, 1 and 4 का agonist. Do remember the name of the drug will be your prucalopride. Prucalopride. ठीक है? They are mainly present at the GIT and they are going to increase the motility of the intestine. They are going to increase the motility. ठीक है, इसमें थोड़ा डल आ रहा है, but don't worry, on the PDF it will be coming very correctly. I don't know what is the problem, है ना? 5-4 का agonist will be using, and they will be increasing the intestinal motility. We can use the name of the drug that I told you will be prucalopride. We had other drugs in the same, that is cisapride, mosapride, ticacerot. We are not using them because of the QT prolongation as a risk. We are not using them. So in which scenario you can use them? Prucalopride. Any condition that is associated with constipation, like irritable bowel syndrome वाला constipation, opioid induced constipation, किसी भी patient of constipation में we can use. Other drugs that we had here, the name of the drug are cisapride, the name of a drug is mosapride, the name of a drug is ticacerot. We are not using them. Again, they were actually associated with your QT prolongation as a side effect. We are not using them. So quickly, what we have seen here in the simple one slide, I have summarized you important serotonin वाले drug, important histamine वाले drug. Histamine 1 वाले anti-allergic drug होते हैं, 2 वाले anti-ulcer drug होते हैं, mainly utilized in the treatment of peptic ulcer disease. 5-3, they are present in the CNS, they cause sedation, and when we give inverse agonist, they will be increasing the wakefulness. Tiprolizin, pitolisant, they are the inverse agonist. 5-4 ka, we don't have any drug. 5-1, 2, 3, 4, again I have given you important point to remember that their G protein, which of the following is the only one acting by GS, that is going to be 5-4. Which of the following does not act by G protein, that is 5-3. They are actually mediated by ion channel. And what is the name of a drug? The name of a drug is very simple, your ondansetron, granisetron, palanosetron, all the cetrons that we have. Now let's do important question on the basis of this topic. It's your time now to tell me very quickly what is the inverse agonist of S3 that is used in the narcolepsy. Inverse agonist of S3 that is used in the narcolepsy. Can you guys tell me? Fast. S3 का inverse agonist. T3 से याद कर लीजिए tiprolizant. And then we also have pitolisant, tiprolizant and pitolisant. H1 antagonist that has maximum antihistaminic activity and maximum anticholinergic property. The name of a drug will be your promethazine. Do you guys know that promethazine can be utilized in the management of allergy? Yes, it can be utilized in the management of allergy. It can also be utilized for the management of the extrapyramidal symptom. Do you know that it can also be utilized for the motion sickness? If hyoscine is not there, this is the next best first line agent that you can use. Least sedative H1 antagonist. Now, if it is going to ask from the first generation, if the word is specifically first generation, please mark chlorpheniramine. Please mark chlorpheniramine. If it is going to ask overall or from the second generation, then your answer will be your fexofenadine. Fexofenadine is the overall least sedative. Fexofenadine. Estemizole, terfenadine, and not used because of the QT prolongation. H1 antagonist for allergic conjunctivitis, we have olopatadine. It's available in the eye drop form. We are using it for the allergic conjunctivitis. Other term that is used here is known as your spring qatar. एक और term use करते हैं, उसका नाम क्या होता है? Spring qatar. There is one more drug here, L-caftadine. L-caftadine is one more drug that we have here. What is the name of 5-HT2C agonist that is used for obesity? Again, there is an exception that 2 ka I told you that we are going to use antagonist, 2 and 3 ka antagonist, but here there is one exception. 5-HT2C agonist जो load को कम कर दे, that is lower carcerin. ये load को कम करने वाले drugs हैं, ठीक है? Then we have triptans. Do remember that they are the 5-HT1B by D agonist. Do remember they are the drug of choice, and triptans are also the drug that can increase the risk of vasoconstriction, or it can precipitate acute coronary syndrome. It can also precipitate acute coronary syndrome. Therefore, we have one more new drug here that is coming from the 5-HT1F agonist. This is also a presynaptic receptor. They are also an autoreceptor. The name of a drug will be your lasmiditan. तो इसको कैसे याद करेंगे? They can cause acute coronary syndrome. They can cause MI. But lasmiditan less MI का risk. They have less MI का risk. Lasmiditan 5-HT1F agonist. They are mainly present on the presynaptic neuron. They inhibit the release of the CGRP. Unlike triptans, 5-HT1B वाला जो है, B is present on the blood vessel. They cause vasoconstriction. D वाला will inhibit the release of the CGRP. Okay. Here your ondansetron, granisetron, pelanesetron, any of them will be the drug of choice in chemo-induced nausea and vomiting. Methotrexate will be causing a side effect known as your pleuropulmonary fibrosis. Do remember that apart from this, other drugs that can cause pleuropulmonary fibrosis will be your bromocriptine, right? Bromocriptine. Don't you guys know that our drugs like your bleomycin can also cause? Busulfan can also cause. Busulfan, bleomycin, they all can cause your pleuropulmonary fibrosis. This is not the one. This is not the end actually. We have other agents like, for example, your gold, methotrexate, chloramphenicol. They all can actually cause pulmonary fibrosis. And in one of the examination they asked, and option had which of the following does not cause fibrosis. Our option has metformin. Remember, metformin does not cause fibrosis. Precursor of prostaglandins, very simple. We have phospholipid, which is converted to arachidonic acid, which will be converted to either prostaglandin or leukotrienes. I think pretty simple. Prostaglandins or leukotriene, depending on the type of enzyme that is going to work. मेरे iPad पे सही चल रहा है. I don't know what is problem here on the screen. Prostaglandins and leukotriene, है ना. Here prostaglandin के लिए what is the precursor? Arachidonic acid. The answer for this question will be arachidonic acid, and the name of enzyme will be cyclooxygenase here, and the name of enzyme that is going to act here will be 5-lipoxygenase. 5-lipoxygenase. Can you guys tell me that phospholipids that is being converted to arachidonic acid with the help of enzyme phospholipase A2? What is the name of drug that is acting by inhibiting phospholipase A2? Phospholipase A2 inhibitor कौन होगा? So this will be inhibited by steroids. Steroids will be inhibiting phospholipase A2. COX inhibitor will be very simple. That is going to be your NSAIDs. Can you tell me what about the LOX inhibitor? 5-lipoxygenase inhibitor. LOX will be your, the name of the drug will be your Xilutone. Again a very simple question. 5-LOX inhibitor will be Xilutone. तीनों के तीनों क्वेश्चन हैं आपके एग्जाम के, ठीक है, पहले भी पूछे गए. Effect of prostaglandin in fetus, it maintain the ductus arteriosus patency. Ductus arteriosus patency. That is why the question that was asked, that in the third trimester, if the pregnant female is exposed to COX inhibitor, there will be premature closure of ductus arteriosus. Okay. What is the prostaglandin analog used for cervical ripening? This will be your misoprostol, dinoprostone. PGE1 analog that is used for IBS with constipation. IBS with constipation, irritable bowel syndrome with the constipation. Can you tell me IBS with constipation? Name of drug will be lubiprostone. ये इंटेस्टाइन को lubricate कर देगा. lubiprostone कैसे करेगा? They will be acting by increasing the chloride channel का activity. By increasing the chloride channel का activity or chloride channel का action, they will be causing a passive influx of water. है ना? By increasing the chloride channel activity, they will be increasing the water का influx in the lumen. And because of the water का influx in the lumen, there will be more water inside the lumen, and that will be promoting intestinal peristalsis, and there will be relief from the constipation. Drug of choice for acute gouty arthritis, you can use the drugs like your NSAIDs. Please do remember that do not use aspirin. Exception is your aspirin. Chronic gout, you will be using xanthine oxidase inhibitor, drugs like your allopurinol, which I have already told you in the previous slide. Allopurinol, febuxostat, which everyone is aware. Uricosuric agent that is used for the gouty arthritis. Uricosuric, the one that is going to increase the excretion of uric acid, will be uricosuric. So what are those drugs? Probenecid, lesinurad, lesinurad, benzbromarone, sulfinpyrazone, all of them are uricosuric agent. Sulfinpyrazone is a uricosuric agent. Lesinurad, benzbromarone, they are also uricosuric agent. Okay, so these are the 4 agents, right? 4 agents are there under this one. 1, 2, 3, 4. Drug of choice for rheumatoid arthritis, we all know methotrexate, that will be one of the dihydrofolate reductase inhibitor. Calcineurin inhibitor causing gum hypertrophy. So gum hypertrophy, a very common side effect associated with phenytoin. Gum hypertrophy, very common side effect associated with phenytoin. But among the calcineurin inhibitor, the name of the drug will be your cyclosporine. This can also lead to your gum hypertrophy. Fastest acting, leflunomide. ये उड़ जाएगा, leflunomide, flu वाला, leflunomide, right? Cyclosporine, they are one of the cyclosporine. They are one of the drugs that are going to cause gum hypertrophy. They are the calcineurin inhibitors. Other immunomodulators that all of you guys should know in the examination, examiner will be giving you which of the following is a TNF alpha inhibitor. TNF alpha, one of the very important inflammatory cytokine, pro-inflammatory cytokine. And I used to give you that, remember the mnemonic ice के ऊपर आग, या ice and आग. Ice and आग will be your infliximab, certolizumab, etanercept, adalimumab, and other one will be your golimumab. Adalimumab and golimumab, ice के ऊपर आग, याद रहेगा, ice and आग. Interleukin 1 inhibitor will be your anakinra. 1 is the first letter that can be utilized, RA, for rheumatoid arthritis. So they all can be utilized in rheumatoid arthritis, inflammatory bowel diseases. Interleukin 2 inhibitor will be your drugs like your daclizumab. So D से 2 याद कर लो, daclizumab. These are interleukin 2, and other name for this one will be your anti-CD25. Interleukin 2 and anti-CD25. There is one more drug in this one known as your basiliximab. ठीक है? Okay. All of them are monoclonal antibodies. Remember interleukin 6. So I used to tell you that, remember tocilizumab. So इसके नाम में एक वर्ड आ रहा है, 6 वर्ड आ रहा है, देखिए tocilizumab. I want you to read it as a tocilizumab. Tocilizumab is tocilizumab. ठीक है? Then as rightly said by one of you is sarilumab. S for 6, sarilumab. Co-stimulation inhibitor will be your abatacept, belatacept. Abatacept and belatacept. These are the co-stimulation inhibitor, abatacept and belatacept. Is it very difficult? Don't you guys have already read this all? That is coming or mainly acting between, है ना? They are mainly going to act between, है ना? CD28 of T cell, right, and CD80 of antigen presenting cell. T for 28 and T for T cell, 80 antigen presenting cell. इसके बीच में आएगा, right? These are the co-stimulation inhibitor. They are what? They are the co-stimulation inhibitor. What are they? They are also the immunomodulatory agent, mainly utilized also in a condition like immunomodulatory like post-renal transplant, rheumatoid arthritis, 80 and 89, 28 and 80. ठीक है? Abatacept and belatacept. I hope all of you guys can remember this actually. Very, very easy. Okay. Now, do you know there is someone called your mTOR inhibitor, mammalian transcription of rapamycin? Expect this question. mTOR inhibitor, mTOR inhibitor. Which one will be mTOR inhibitor? Mammalian transcription of rapamycin. This will be okay. mTOR inhibitor. Sirolimus, everolimus. Sirolimus, everolimus. These are the mTOR inhibitors. That is also one of the immunomodulatory agent that can be used. Do remember sirolimus is also given in our cardiac implants. ठीक है, जो स्टेंटिंग आप करते हैं उसमें भी बिकॉज ऑफ देयर एंटी प्रोलिफरेटिव एजेंट वी आर यूजिंग देम. ओके, नाउ टारगेटेड एंटी कैंसर विच आर द इंपॉर्टेंट दैट यू शुड नो एट ऑल पॉइंट ऑफ टाइम will be drugs like your bortezomib, carfilzomib. These are the proteasome inhibitor. Do remember them. Proteasome inhibitor, right? Remember zomib. ये zombie वाले drug है. Zombies like protein. Zombies like what? Protein. And they are mainly utilized as a drug of choice in a patient with the multiple myeloma. Olaparib, rucaparib, niraparib. What are these? These are the poly-ADP ribose polymerase inhibitor. PARP inhibitor. ठीक है? PARP inhibitor. Yes, you can also use post-renal transplant for the prevention of Dr. Turtle. Yes, drug eluting stent में हम इसको यूज करते हैं बिल्कुल. And use for prevention of graft failure. Exactly. ठीक है. Olaparib, rucaparib, niraparib. So नाम में ही है देखिए poly-ADP ribose polymerase inhibitor, and they are mainly used in the BRCA mutated ovarian cancer. You can very easily remember. Ola वाला रुक नहीं रहा. That is olaparib, rucaparib, niraparib. Then we have certain cyclin dependent kinase inhibitor, that is inhibiting cyclin dependent kinase 4 and 6. Palbociclib, ribociclib, abemaciclib. नाम में है cyclib. abemaciclib, CICLIB. Palbociclib, ribociclib, abemaciclib. These are the cyclin dependent kinases inhibitor, mainly utilized in a patient with a breast cancer. ठीक है, breast cancer. Okay. Apart from them, you have all the tyrosine kinase inhibitor, which everyone knows that they are all ending with nib, and all of them are orally available. Unlike monoclonal antibodies that are given by the injectable route, always either IV, subcutaneous, IM. Injectable हैं always. ठीक है. Vandetanib, again tyrosine kinase inhibitor. All of them are tyrosine kinase inhibitor. Imatinib mesylate is the drug of choice in a patient with the CML. Sometimes they don't use the term CML. They use a patient with the translocation 922, Philadelphia chromosome जहाँ पे होता है. ठीक है. They are also the drug of choice in a patient with the GIST, gastrointestinal stromal tumor में भी these are the drug of choice. In another examination, examiner asked, okay, in a patient with CML, imatinib was given, it was not effective. Okay, what is the next drug that you can use? If it is a non-responsive NR, then we are going to use second generation tyrosine kinase inhibitor. And second generation tyrosine kinase inhibitor, I used to say that our DNB post is always secondary. Just a way to remember, DNB wala post. So what does DNB wala post stand for? DNB wala post. What does DNB wala post stand for? So we have dasatinib, nilotinib, bosutinib, ponatinib, right? These are the drugs that are coming as second generation tyrosine kinase inhibitor in a non-responsive cases of imatinib mesylate. Lapatinib, mainly preferred in a patient with the breast cancer. Sorafenib, hepatocellular carcinoma. Sunitinib, it's a preferred drug in a patient with the renal cell carcinoma. Examiner also asked, all of the following tyrosine kinase inhibitor can be used in renal cell carcinoma except. So remember, for the renal cell carcinoma, you will be remembering 4 drugs. So in the renal area, we always get spasmodic pain. Spas stands for your sunitinib. That is the preferred tyrosine kinase inhibitor. It's the preferred tyrosine kinase inhibitor. P for your pazopanib. A for axitinib. And as for sorafenib, it's the preferred tyrosine kinase inhibitor in a hepatocellular carcinoma, but we definitely can also use in a patient with the renal cell carcinoma. Vandetanib, medullary carcinoma of thyroid में we can use vandetanib. ठीक है, medullary carcinoma of thyroid में we will be using vandetanib. Then when you will download the PDF, you will be getting some of the important monoclonal antibodies that are self-explanatory, like virus के लिए respiratory syncytial virus के लिए palivizumab, eculizumab for paroxysmal nocturnal hemoglobinuria. They are the monoclonal antibody against complement 5. Omalizumab against IgE, Mepoli and Restli against interleukin 5. They are used for bronchial asthma and COPD. Daratumumab and Isha. So Dara and Isha, they are from the same age group. So remember, they are used in multiple myeloma, and they are actually anti-CD38. So I used to say that Dara and Isha, they fell in love at the age group of 38. At the age group of 38, they both fell in love. Okay. Then we have cetuximab, epithelial growth factor receptor inhibitor, and rituximab. It's one of the anti-CD20 monoclonal antibody. Ritu कितने साल की थी? Ritu is in 20 का एज ग्रुप. Dara and Isha 38 का एज ग्रुप, है ना. Then ibalizumab, it's the one monoclonal antibody that is for the HIV-1. Against ibalizumab that we have, ibalizumab, it is against CD4 cell receptor. CD4 cell receptor. Itolizumab for the chronic plaque psoriasis. When you download the slide, you will be getting all of them, and most of them I have already told you. Like for example, idarucizumab for dabigatran toxicity, alirocumab, evolocumab, right? They are the PCSK9 inhibitor, right? These are the self-explanatory slides that we already have in our PDF. All right. Then one more topic that is being asked nowadays in INICT and also in NEET PG. I'm expecting if they are going to follow the same trend, one question can be asked in your examination. That will be from the topic of programmed death cell 1 receptor antagonist, PD1 antagonist. They are also known as your immune checkpoint inhibitor. Immune checkpoint inhibitor. And what is the name that I used to give for this immune checkpoint inhibitor? These are PAN card. So if you have a PAN card, you will not be checked at the checkpoint. Just a way to remember. Immune checkpoint inhibitor. PAN card stands for your drugs like your pembrolizumab, atezolizumab, pembrolizumab, atezolizumab, nivolumab, and semiplimab. Please remember that there are many other immune checkpoint inhibitors, but important ones are these four. If you remember these four, your work will be done. Semiplimab, it is mainly preferred for squamous cell carcinoma of the skin and squamous cell carcinoma of the lungs. Other agents that we have like pembrolizumab, atezolizumab, nivolumab, they can be utilized in a condition, remember by the mnemonic LUNCH, LUNCH, that stands for Lynch syndrome. Oftentimes, this Lynch syndrome is also associated with your colorectal carcinoma, urothelial carcinoma, non-small cell lung cancer, colorectal carcinoma, Hodgkin's lymphoma. This has been asked already in INICT. Head and neck cancer maybe also we can use. So remember, programmed death cell 1 antagonist. First and foremost, they are immune checkpoint inhibitor. How to remember the name? The simple mnemonic that I told you will be PAN card. PAN, PAN card. Pembrolizumab, atezolizumab, nivolumab, semiplimab. Pembrolizumab का March 2022 में they have also been approved for advanced endometrial carcinoma. For advanced endometrial carcinoma, which agent that I am talking about? Pembrolizumab. इसका एक और approval हुआ है अभी recently in the month of March April 2022, and the same mid-year June वाले AIMS में they have already asked this question in the examination. Okay. All right. And when you will download the slide, you will also be getting some other hormonal anti-cancer agents that I have already summarized here. It's a self-explanatory. What are the SERMs that we have? What are the SERDs? Fulvestrant is a SERM. SERD, remember, selective estrogen receptor down regulator. Please don't forget that. And aromatase inhibitor. We also have a GnRH agonist that can be used in prostatic carcinoma. Leuprolide, goserelin, historyline, and antagonist will be Relix. And ठीक है, एंड्रोजन रिसेप्टर एंटागोनिस्ट लाइक फ्लूटामाइड, निलूटामाइड, ऑल दीज एजेंट्स you will be finding when you download the slide. Now some important CNS and CVS drug जो आपको हर समय जानना चाहिए at all point of time that you should know, that is going to be anti-epileptic drug. First and foremost I'll be starting with the anti-epileptic drug. Now anti-epileptic drug, your aim of the therapy should always be try to decrease the level of glutamate or try to increase the level of GABA. Either decrease glutamate or increase the level of GABA. And we all know that if this is one of the glutamate receptor, glutamate neuron that stores the glutamate, and whenever glutamate is released, it will be acting on its receptor. What are the receptors that we have? We have receptors like your NMDA, we have receptors like your AMPA, we have receptors like your mGlur5 receptors. For the release of the glutamate, we need some important points to remember. One will be, there is someone known as your voltage gated sodium channel. This is the most predominant channel that is responsible for the depolarization of the neuron. Then not much but some very sparsely we also have neuronal type calcium channel, N type calcium. I'm not writing T type, I'm telling you N type calcium channel. So the influx of calcium will also be causing depolarization. And always remember, if you want the depolarization of the neuron, on the presynaptic neuron, if there is a potassium, always remember whenever potassium channel is open, there will always be efflux of the potassium. Therefore, we should block this potassium. We should block this. I mean, the potassium should be blocked. Now, ideally, the potassium should be blocked for the depolarization of the neuron. Potassium should be blocked. Okay. Apart from that, when it is open, there will be efflux of the potassium, and that will be adding on to the hyperpolarization, and that is exactly what we want. If you want to cause hyperpolarization of the neuron, or if you want to inhibit the depolarization, you can do few of the important things. One you can do will be, you can block the voltage gated sodium channel, you can block the N-type calcium channel, and you can keep this voltage, potassium channel open. You can keep this potassium channel open. The drugs that can keep the potassium channel open will be your retigabine. The drug that can keep the potassium channel open will be your retigabine and ezogabine. The drug which can block the sodium channel will be all the major anti-epileptic drug like your valproate, carbamazepine, phenytoin, all the major anti-epileptic drug that you can think of. Whatever major anti-epileptic that you can think of, they all will be acting by voltage gated sodium channel blocker. Phenytoin, topiramate, lamotrigine, please do remember that. N-type calcium channel blocker that we have. What are the N-type neuron type calcium channel blocker? That will be your pregabalin. Then we are also having gabapentin. Pregabalin, gabapentin. Pregabalin, gabapentin. And then we have other drugs like lamotrigine and all. They also have N-type neuron type calcium channel blocker. And in fact, examiner has also asked their uses. So they are the drug of choice in a patient with a neuropathic pain. Neuropathic pain like post-herpetic neuralgia, sciatica, post-herpetic neuralgia, and they can also be utilized as a drug of choice in a patient with the diabetic neuropathy. Diabetic neuropathy. Currently, we are also preferring them in a patient with the restless leg syndrome. In a restless leg syndrome also, we are preferring this class of drugs. That is going to be pregabalin, gabapentin. Can we also use them in migraine? Yes, we can also use them in a patient with the migraine as well. Then we are left with the NMDA blockers and other receptor blockers that we can use. Definitely we can block. Like for example, if I talk about NMDA blocker, what is the name of a drug? That will be your felbamate. AMPA blocker will be your perampanel, right? Quickly you can see telampanel, perampanel, telampanel. mGlur5 receptor blocker will be your rufinamide, that is receptor 5, rufinamide. Okay, rufinamide, that is mGlur 5 receptor blocker. Okay. Not only that, in the presynaptic neuron, we also have found there is one particular protein known as your SV2A protein. SV2A normally modulate the release of glutamate, and at the same time it holds the GABA. It holds the GABA. Whenever SV2A is activated, SV2A it modulates glutamate and it holds the GABA. Therefore, the next target that you can do will be SV2A inhibitor. You can also give your patient one of the SV2A inhibitor, synaptic vascular 2A protein inhibitor, and this drug will be your SV2A inhibitor. Please don't forget, very important drug, SV2A inhibitor. This will be your levetiracetam, and other one will be your brivaracetam. Levetiracetam and other one will be your brivaracetam. SV2A inhibitor. These are considered the drug of choice for epilepsy in pregnancy. Drug of choice for epilepsy in pregnancy. Levetiracetam and brivaracetam, they are the drug of choice for epilepsy in pregnancy. Don't forget that. Okay? Drug of choice for epilepsy in pregnancy will be levetiracetam, brivaracetam. Then these are the again anti-epileptic drug that is acting by voltage gated sodium channel blocker. Do remember their important non-epileptic uses. Their important non-epileptic uses. Important drug of choice like anti-epileptic drug of choice for pregnancy will be levetiracetam. Alternatively, we can even use lamotrigine. Seizure during pregnancy, we also call them eclamptic seizure, MGSO4. Generalized tonic-clonic seizure, we can prefer lamotrigine. If it is not there, we can even go ahead with the valproate. Drug of choice for atypical absence seizure, myoclonic seizure, atonic seizure. In a patient with the Dravet syndrome, in a patient with Lennox-Gastaut syndrome, for all of them, we have the drug of choice, sodium valproate. But if the examiner is going to ask you for absence seizure, drug of choice for absence seizure, then in that case scenario, you will be choosing ethosuximide. That is one of the T-type calcium channel blocker. Focal onset partial seizure, we have carbamazepine. It's also the drug of choice in a patient with the trigeminal neuralgia or glossopharyngeal neuralgia. I am talking about the drug that is carbamazepine. Febrile seizure mein, we have the drug of choice that is diazepam, perrectal diazepam. IV lorazepam is the drug of choice in status epilepticus. Infantile spasm. Infantile spasm, what is the drug of choice, guys? We are going to use the drug of choice in infantile spasm. That is your ACTH. And vigabatrin will be the drug of choice. Infantile spasm with tuberous sclerosis, absence seizure with ethosuximide. I think it's given here already. Important drug of choices in different types of seizure I have given you already. I think the iPad is not supporting. Allow me a minute. I'll just bring my iPad, and we have half an hour session left, and then we will finish our session after half an hour. Okay, just allow me just 1 minute. I'll be back with my charger here. Okay, जब तक आप एक ब्रेक ले लीजिए 2 मिनट का. मैं लाइव रह रहा हूँ, कुछ पानी नहीं पी लीजिए, मैं आता हूँ, बस 2 मिनट में आता हूँ. जस्ट अ मिनट. Okay. Hi guys. Sorry for the short interruption. I'm back here. So can we finish now the remaining portion? A quick thumbs if I am audible now. Everything is fine. Okay. We can start? Okay, thank you. So a couple of questions that we have again from this area. For the prevention and arrest of the convulsion, we will be using a drug from benzodiazepine known as diazepam. For acute, again from the benzodiazepine, we can use chlordiazepoxide, that is used in the acute alcohol withdrawal. In a resistant hypertension, we will be using aldosterone receptor antagonist, spironolactone. Renoprotection in diabetic patient or in a patient with the chronic congestive heart failure, the best drug is none other than your ACE inhibitors. Calcium gluconate will be the drug of choice in a patient with the hypocalcemic tetany. For trichomoniasis, we will be using which kind of drug? That will be your metronidazole. It is also the drug that will be causing disulfiram-like reaction. Among the antipsychotics, maximum risk of extrapyramidal symptom, it is always and always associated with your typical antipsychotics. It will always be less than the atypical. Atypical के साथ ये नहीं होता है basically, but some drugs can definitely cause. So maximum risk among typical will be none other than your haloperidol, and least risk will be your thioridazine. Least risk will be your thioridazine. Then there comes the atypical antipsychotics. Do remember that atypical is not supposed to cause extrapyramidal symptom, but there is one risky drug known as your risperidone. A risky drug is your risperidone. This is the most potent atypical antipsychotics. The one that is overall least and you can say no extrapyramidal symptom will be your clozapine. They do not have extrapyramidal symptom. Overall least or no extrapyramidal symptom. Which atypical can cause arrhythmias? The atypical that can cause arrhythmia will be sertindol, zotapine, sertindol, ziprasidone, they all can cause cardiac arrhythmias. What about your clozapine? Remember, they definitely will be causing side effect like your metabolic side effect, like weight gain, insulin resistance and all. Apart from that, they will be causing other side effects like your agranulocytosis, sialorrhea, which is salivation, wet pillow syndrome भी बोलते हैं, sedation, seizure, and one of the cardiac side effects that they cause, they are also going to cause myocarditis. This has also been reported side effect. The earliest extrapyramidal symptom, 3 important questions. Earliest will be your dystonia. Most common will be akathisia, which is commonly treated with the propranolol. And the dangerous extrapyramidal symptom that we have, which is the most dangerous extrapyramidal symptom, that will be neuroleptic malignant syndrome is the dangerous extrapyramidal symptom. What about the drug of choice for dystonia? Again, you can use centrally acting anticholinergic drug like your benztropine, benzhexol, or you can even use promethazine, one of the antihistaminic drug having centrally acting anticholinergic property. Neuroleptic malignant syndrome, you can use, earlier we were using dantrolene, but now currently the antidote will be your bromocriptine. But we have not stopped dantrolene actually, we will be adding dantrolene. But the antidote currently is your bromocriptine. Do remember, dantrolene is the drug of choice for malignant hyperthermia. Atypical with the least weight gain. So I have given you the story, Aripiprazole को देखा क्या? So aripiprazole, ziprasidone. Aripiprazole को देखा क्या? Very very simple mnemonic to remember. They have less weight gain. The one that can cause weight loss, there is one that has been shown in some studies, molindone, from the miscellaneous group of antipsychotics. Maximum hyperprolactinemia. So which one is going to cause the maximum hyperprolactinemia? Again, among atypical, I told you there is one risky drug. And what is the name of that risky drug? So you remember that they will also be the same drug that is also associated with the extrapyramidal symptom. So that is your risperidone. That's why I call it as a risky drug. It is your risperidone. corneal opacity, retinal pigmentation, they both will be associated with thioridazine. An antipsychotic drug that is causing antipsychotics. Among antipsychotics, the one that can cause cataracts, that will be your quetiapine. So again in our story it comes Andhirani, queen, and a quetiapine, Andhirani. Then don't forget drugs causing disulfiram-like reaction due to inhibition of the enzyme aldehyde dehydrogenase enzyme inhibition. They will be causing disulfiram-like reaction, and mnemonic for this one will be your Government Medical College of Madhya Pradesh and Chhattisgarh. यहाँ पे आपको disulfiram-like reaction मिलेंगे. Now another question asks, which anti-amoebic drug? Metronidazole. Which antifungal drug shows disulfiram-like reaction? Griseofulvin. Which cephalosporin shows disulfiram-like reaction? So Titan के ऊपर मन डोले है मेरा सिफोटिटैन, सिफोपेराजोन, सिफोमेंडोल. Moxalactam is also one of the cephalosporin. ठीक है. Procarbazine and anti-cancer drug. Chlorpropamide, it's the first generation sulfonylureas. Which is the first generation sulfonylureas? Chlorpropamide is the first generation sulfonylureas. Okay. Then you should also know about the antidepressants. Like for example, citalopram, escitalopram, they are all SSRIs, SSRIs, and their side effect is also SSRI. That is your serotonin syndrome, nausea, vomiting, fluctuation in blood pressure, headache, sexual dysfunction, like delayed ejaculation, restlessness, and insomnia. The side effect of SNRI is also same as SSRI. They will have many more side effects. Who will have more side effects? Like TCAs. Tricyclic antidepressants are going to have many more side effects. That is why they are used as a second line mainly in depression. Because of antihistaminic property, they will be causing sedation. Because of anticholinergic property, they will be causing blurring of vision. They will be causing dryness of mouth. They can even lead to severe constipation. Okay. They can also have multiple other side effects like alpha-1 blockade. They can cause postural hypotension, fall in the blood pressure, and postural hypotension. They will also be causing fall in the blood pressure, sudden fall in the blood pressure. They can also lead to metabolic acidosis, and as I told you, because they are causing metabolic acidosis, they can also induce arrhythmia. And this metabolic acidosis that is causing arrhythmia, that is why we are using forced alkaline diuresis for the management. Use of methadone, remember opioid de-addiction में we are mainly using this methadone. Potent opioid will be your sufentanil. Which is around 1,000 times more potent compared to your morphine. Naloxone, again, it's the antidote of acute opioid poisoning, acute morphine poisoning, or antidote for acute opioid poisoning, morphine poisoning. Naltrexone, nalmefene, remember nalmefene, again, they are alternative to naloxone. Naltrexone, it is used in a de-addiction therapy after methadone substitution therapy. They also use as an anti-obesity drug, right? Nalmefene, they will be utilized as an anti-obesity drug, and they also actually decreases alcohol craving. That's an additional property of naltrexone. They will be decreasing the alcohol craving as well. Yes, बार बार सॉफ्टवेयर क्रैश हो रहा है. I should use a different software, I guess, for mirroring. They decrease the alcohol craving as well. Okay. Yes, it's fine now. I think बार बार software crash हो रहा है कोई एक. I have to choose a different software. If you guys know any other software, you can suggest me. SSRI is the drug of choice for OCD, panic disorder, for all of them. Date rape drug among benzodiazepine will be your flunitrazepam. So after a date, there was a rape, and after that he flew. So flunitrazepam. Inverse agonist of benzodiazepine, that is beta carbolin. And do not forget albumopan. They are actually the peripheral mu opioid receptor antagonist. So they are albumopan, naldemedine, है ना? They are mainly utilized in the opioid induced constipation. In which scenario? Opioid induced constipation without causing withdrawal symptom. Remember, that's a very important thing, that without causing withdrawal symptom, we can use this class of, without causing withdrawal symptom, we can use this drug in a patient with the opioid induced constipation. Withdrawal symptom nahi karega, unlike naloxone and all, they can also be used, but they will definitely cause your withdrawal symptoms. Okay. All right. Then, can you tell me what is the antihypertensive drug that is causing Coombs positive test? Coombs positive. Antihypertensive drug that is causing Coombs positive? Anyone? Then this is one of the PYQ, past question hai ye. It has been one of the PYQs that has been asked in the past. Antihypertensive is causing Coombs positive test. So that will be your alpha methyl dopa. Renin release inhibitor, guys, this is going to be your beta blockers. However, if the examiner is simply going to ask you which of the following is a renin inhibitor, the answer to this question will be none other than your aliskiren. ACE inhibitors, some most common side effect will be your dry cough. Many of the time examiner also ask that okay, if there is angioedema and they give you image, है ना, angioedema का image देते हैं. So this is mainly occurring due to which of the following inflammatory cytokine? So this is because of the bradykinin mediated. ARB having anti-aggregant because of thromboxane A2 property. ARB that can decrease the uric acid level. ARB that can decrease the LDL level. The answer to all of them is going to be losartan. Lowers everything will be none other than your losartan. Okay. Then what is the side effect of amiodarone that we have? Amiodarone, remember, antiarrhythmic drug. It is one of the class 3 antiarrhythmic drug. Amiodarone is one of the class 3 antiarrhythmic drug. So they have multiple side effects actually. The important one, like for example your thyroid abnormality, this happens to be the most common side effect. This can go in either direction. It can actually go in hyperthyroidism or hypothyroidism both. They can also lead to your QT prolongation, liver toxicity, corneal microdeposits, जिसको बोलते हैं cornea verticillata, corneal microdeposits. So if the examiner asks you which of the following investigation you will be asking on follow-up, है ना, pulmonary fibrosis is also one of them. Pulmonary fibrosis is also one of the side effects. Which of the following investigation you will be asking on follow-up? You can ask for the TSH level or thyroid function test. LFT you can ask, ECG you can ask, है ना. Levosimendan, है ना, levosimendan. They are coming from the class of phosphodiesterase 3 inhibitor. Other drugs in this same class will be your ambrinon. Other drugs from same class will be your ambrinon, milrinon, milrinon. They are also known as your inodilators. Phosphodiesterase 3 inhibitor mainly utilized in a patient with the chronic congestive heart failure. Digoxin, directly they act by inhibiting sodium potassium ATPase, and indirectly they increases the intracellular calcium that will be causing inotropic effect. The most common side effect will be nausea and vomiting for digoxin, and do remember that they will also be associated with the hyperkalemia. That is an important one. And a specific side effect of digoxin, if the examiner is going to ask you, you will be marking a specific side effect known as your xanthopsia being a specific side effect. Trimetazidine, ranolazine, try running aaj se hi if you want to burn your fat. So fatty acid oxidation inhibitor. But if the examiner specifically asks you what is the main mechanism of action of ranolazine, that is the late sodium influx inhibitor. This is the main mechanism of action. Xanthopsia is yellow vision. But if the examiner asks which of the following drug causes cyanopsia, associated with your favorite blue pill, that is your sildenafil. the favorite blue pill used, sildenafil, that will be causing cyanopsia. Fasudil, फंसा हुआ दिल रोता रहता है, that is rho kinase inhibitor. They all are mainly utilized in which scenario? Both of them are utilized mainly in a patient with the angina. Okay? Don't forget cyanopsia, that is being caused by your blue pill. Cyanopsia is blue vision, that is caused by sildenafil. Xanthopsia, as I have already told you. Okay? Then anti-dyslipidemic drugs. Okay. So how did you remember rho kinase inhibitor? Fasudil. How did you remember Fasudil? Fasudil sounds like fasa hua dil. Okay, Fasudil sounds like fasa hua dil. They are the rho kinase inhibitor. Now, what is the mechanism of action of these anti-dyslipidemic drugs? Mechanism of action of these anti-dyslipidemic drugs. So quickly, let's talk about these anti-dyslipidemic drugs. What are the names that we have? What are the names that we have? Ezetimibe. They inhibit the cholesterol absorption from the intestine. Inhibit the cholesterol absorption by inhibiting your NPC1 L1 like receptor from the intestine. Alirocumab, evolocumab, as I told you, PCSK9 inhibitor. Ali is evolved as PCS, so alirocumab, evolocumab. That is a mnemonic actually. Ali is the name of a person. Ali is evolved as a PCS. Okay. Lomitapide, the name itself is having the answer. Microsomal triglyceride transfer protein inhibitor, that is going to be your MTP inhibitor. Anacetrapib have not got FDA approval, that they are the CETP inhibitor. Cholesterol ester transfer protein inhibitor. EPO is MIPO. EPO is MIPO. ऐसे याद करना है. MIPOMERSEN, they are the ApoB100 synthesis inhibitor. ApoB100 synthesis inhibitor. Volanesorsen, they are the ApoC3 synthesis inhibitor. ApoC3 synthesis inhibitor, that is your Volanesorsen. Quick, simple, clear. Is having heater noise? No, there is no heater here. I think maybe my laptop is creating all this noise. Sorry for this background noise. Okay. Fibrate, that is having uricosuric. First and foremost, fibrates are PPAR alpha agonist. Alpha, phi is phi, fibrates. The one that is having uricosuric will be your phenofibrates. Therefore, in a history of a gout patient, which of the following fibrates is preferred? You are going to use phenofibrate. Anti-dyslipidemic drug of choice in child and pregnancy. Expect this question. Okay, that is going to be your resins, also known as your bile acid sequestrants. These are cholestyramine, cholesevelam, cholestipol, all of them. Okay. The one that increase the HDL, best drug to increase the HDL, that is none other than your niacin. The best to decrease the triglyceride level, that will be none other than your fibrates. And do remember the mechanism of action of fibrates. They are the PPAR, peroxisome proliferator activated receptor alpha. PPR alpha, that is acting by a nuclear receptor, and they increase the level of lipoprotein lipase. Associated with the flushing, pruritus, maculopathy, that will be again your niacin. Increasing the uric acid level. So see, the one that can increase the uric acid level, that will be niacin. The one that decreases the uric acid level, that will be phenofibrate. Among the anti-dyslipidemic drug, please do not forget this important drugs that we have. Okay. Then other important drugs that I can discuss here very quickly. For cystic hydatid disease due to Echinococcus granulosus, we have the drug of choice, that is your albendazole. For the burn patient, silver sulfadiazine. Silver sulfadiazine will be used for the burn patient. For tularemia, we can use streptomycin with the doxycycline. Myxedema coma, again we will be using T3. It's a hypothyroid emergency. Hyperthyroidism in pregnancy, we will be using, I think I have already told you, if it is first trimester and second, third trimester. So I have already told you this one. First trimester में PTU, second, third trimester we can use either methimazole or carbimazole. Which anti-diabetic, which of the following bile acid sequestrant approved as anti-diabetic? That is your cholesevelam. And diabetes के लिए which dopamine agonist has been approved? That is your bromocriptine. So bromocriptine has multiple role, one of which will be your diabetes mellitus as well. Remember, bromocriptine can also be used in diabetes mellitus. Alpha glucosidase inhibitor, acarbose, they are mainly associated with GI side effect like malabsorption. They are going to cause side effect like your malabsorption. Alpha glucosidase is mainly present in the intestinal lumen. Acarbose, voglibose. So you should know the name of the drug also. They can also lead to your diarrhea, bloating. All of them are mainly going to be GI related side effect. GLP-1 analog, they can lead to side effect like pancreatitis, hypoglycemia. They can also increase the risk of medullary carcinoma of thyroid, especially if the patient is having family history of medullary carcinoma of thyroid. DPP-4 inhibitor, they will be causing upper respiratory tract infection. They also can cause headache. Pramlintide is an amylin analog. It's also given by the injectable route, and this is also given by the injectable route. So injectably, if the examiner is going to ask you which is given by the injectable route, it's not only insulin. We have GLP-1 analog, we have amylin analog also. But one GLP analog that has been approved, known as your semaglutide, by the oral route as well. Semaglutide also available by the oral route. They will be causing, pramlintide will be causing side effect like hypoglycemia. They can also lead to side effect like pancreatitis. Remember, जितने भी आइड वाले ड्रग हैं, जो पेप्टाइड वाले आइड हैं, all the peptide वाले आइड ड्रग that we have, they can actually cause your hypoglycemia, like your glipizide, glyburide, glibenclamide. They all can cause hypoglycemia. Yes, you will be getting the PDF of this one. So PDF पढ़ने का उतना टाइम तो मिलेगा नहीं, but definitely if you can read it tonight only, that will be great. ठीक है? So we'll be done in the next 15-20 minutes. We'll be over. We'll be finishing in the next 15 to 20 minutes. हम इसको cover करेंगे. Okay. Next again, SGLT2 inhibitor. The most common side effect that we have for SGLT2 inhibitor will be your UTI. It will also be causing other term that is used is urosepsis. It can also lead to other side effect like ketoacidosis, Fournier gangrene. So please do remember this. Fournier gangrene has been reported already multiple times, and one time the question has been asked already. They will also be causing side effect like weight loss and increasing the fracture risk. Now this fracture risk that we have, it has been denied in the upcoming 2022 studies. They are telling it is increasing the risk of amputation, especially with the canagliflozin, but fracture risk को अब deny कर रहे हैं. Especially in the studies of 2021-2022 में, they are not accepting this fact now. But again, if it is given in the previous ka paper, remember, and in fact fracture risk question has already been asked in the examination. Sulfonylureas, they will be causing side effect like hypoglycemia. They will also be causing side effect like weight gain and agranulocytosis. The sulfonylureas that are mainly used are glipizide, glibenclamide, gliburide. All of them are the sulfonylureas that you can use. Biguanides, they will be causing decrease in the vitamin B12 absorption, and therefore they can lead to peripheral neuropathy and can also lead to your megaloblastic anemia. Fenformin is actually banned because of the side effect known as your lactic acidosis. In fact, this lactic acidosis can also be seen with metformin. Less risk काफी कम है, but definitely can be seen. PPAR gamma agonist, that is your pioglitazone, the name of the drug that we have here, that is going here will be your pioglitazone, that is clinically used. They will be causing sodium and water ka retention. Because of sodium and water retention, remember, there will be one problem known as your weight gain. Now this weight gain is not the same as weight gain seen with the sulfonylureas. Sulfonylurea is going to cause weight gain because they are insulin secretagogue. Sulfonylureas, they act by blocking your ATP sensitive potassium channel. This is another question. ATP sensitive potassium channel. Because of this one, they will be causing further release of the insulin. So we call them as the insulin secretagogue, and insulin has sparing effect over the fat. But here the weight gain is because of sodium and water retention. They can also lead to macular edema. We term it as a cystoid macular edema. Okay? Cystoid macular edema is the term that we are going to use for them. Important antitubercular drug, remember HRZE and S for streptomycin. Doses, if I am going to write here in the mg per kg, if I am going to write dose in the mg per kg, then isoniazid will be 5 mg per kg, rifampicin will be 10 mg, pyrazinamide will be 25 mg per kg, ethambutol that we have will be 15, and streptomycin also 15. Do remember streptomycin not under our NTEP, National TB Elimination Program. We do not have streptomycin. Mechanism of action, isoniazid, they are going to act by inhibiting mycolic acid synthesis inhibitor, and therefore they will be having cidal property. Rifampicin, it's one of the DNA dependent RNA polymerase inhibitor, therefore they will also have cidal property. Pyrazinamide, they are also going to act by inhibiting mycolic acid synthesis, but ये अंदर से काम करेगा. जैसे प्यार अंदर से मारता है, pyrazinamide, pyrazinamide को आज मैं pyrazinamide बोलूंगा, ये अंदर से काम करेगा. This is the one drug that is going to be highly effective intracellularly. It is one of the drug that is most hepatotoxic. जैसे प्यार टॉक्सिक होता है वैसे ये भी बहुत टॉक्सिक है. It should be avoided during the pregnancy, and the mutation gene will be your PNCA gene mutation. Let's fill rest of the table that we have. Ethambutol, thumb jana. So they are again acting by inhibiting one of the very important enzyme known as your arabinosyl transferase. Arabinosyl transferase is the enzyme that is involved in the polymerization of arabinoglycans. Therefore, there is no polymerization of arabinoglycans. Arabinoglycans also are the constituent of the cell wall, but the major constituent will be mycolic acid. For mycobacterium, mycolic acid is the major constituent. Therefore, this is the one class of drug that will be showing static property, and these are the protein synthesis inhibitor. Aminoglycoside is the protein synthesis inhibitor, and this is the one protein synthesis inhibitor that is having cidal property. Which is the protein synthesis inhibitor having cidal? Right now I am telling you one, that is streptomycin, one of the aminoglycoside. They are the 30S inhibitor. Act by causing misreading of the mRNA sequence. Which one is working intracellularly? So as I said, प्यार अंदर से मारता है तो intracellularly. Then streptomycin, strip outside. Rest all other drugs will be effective at both the places, intracellularly, extracellularly, both. But mainly effective or only effective intracellularly? Only प्यार अंदर से. Isoniazid, rifampicin, they are also hepatotoxic, but most toxic will be pyar. Aminoglycoside, ethambutol, mainly toxic to kidney. No drug is 100% safe in pregnancy, but they are relatively safer, and this is contraindicated throughout the pregnancy. Ethambutol relatively safer. If you are going to look at the gene mutation that is causing the resistance, isoniazid will be mainly your CAT-G gene. CAT-G gene will be encoding for catalase peroxidase. CAT-G gene will be encoding for what? Catalase peroxidase. So it is this catalase peroxidase which is mainly involved in the activation of this drug. Isoniazid actually is a prodrug. Okay. So CAT-G, if it is not there, then you can even go for the INHA gene. Here RPO-B gene for rifampicin. Rifampicin के लिए क्या ऐड करना है? RPO-B gene, RNA polymerase B gene. Ethambutol will be EMB-B gene. Streptomycin will be your RRS gene mutation. RRS gene mutation will be causing streptomycin का toxicity. What I am trying to say here, that remember few important points about pyrazinamide. Pyar, mycolic acid synthesis. Pyar ka dose always keep high. So among all the first-line antitubercular drug, the highest dose is associated or with seen with the pyrazinamide. प्यार अंदर से मारता है, that is the one drug that is only or mainly acting intracellularly. प्यार बहुत टॉक्सिक है और प्रेगनेंसी में प्यार को अवॉइड करना है. Please remember few important points. Then when you download the site, all the important side effect of the antitubercular drug has been given. What I would like to highlight here, that which of the following causing hypothyroidism. So remember, ethionamide will be causing hypothyroidism. Para-aminosalicylic acid also causing hypothyroidism. Apart from HRZE, all others are second line drug. Isoniazid, rifampicin, pyrazinamide, ethambutol, all others are second line drug. Second thing that I would like to highlight here, and I'm putting them in red deliberately, that bedaquiline, please remember, B for bedaquiline, it is one of the ATP synthase inhibitor. Therefore they are also producing sidal effect. Delamanid और एक और drug है in the same family, that is your pretomanid. Delamanid and pretomanid, their name have manid and manid, M for manid. These are mainly mycolic acid synthesis inhibitor. Manid and manid are mainly having mycolic acid synthesis inhibitor. So please expect this question in your examination. मैं repeat कर रहा हूँ कौन सा question. Mechanism of action. First and foremost, they are very commonly used nowadays as a second line antitubercular drug, especially in the B-pol regimen. B for bedaquiline. Don't hesitate to mark ATP synthase inhibitor. Manid and manid, pretomanid, delamanid, they are the mycolic acid synthase inhibitor. They are also sidal in nature. Both of them are sidal in nature. ठीक है. Cycloserine causing neuropsychiatric symptom, है ना. Pyrazinamide again causing hyperuricemia, therefore they can also precipitate gout, है ना. Precipitate gout. तो एक और रीजन है pyrazinamide को pyrazinamide कहने का, because प्यार लाइफ में दर्द भी देता है. सो प्यार प्रेगनेंसी में अवॉइड करना है. प्यार अंदर से मारता है इंट्रासेलुलरली, है ना. pyrazinamide, प्यार का डोज हमेशा हाई रखना है. सो अमॉन्ग ऑल द फर्स्ट लाइन ड्रग pyrazinamide इज हैविंग द हाईएस्ट, ठीक है, हाईएस्ट डोज. Okay, so these are all the important drugs that we have. And remember, ceftriaxone is the drug of choice in Mahatma Gandhi ki CCT. So that is meningitis, like listeria meningitis, gonorrhea, community acquired pneumonia, chancroid, and typhoid fever or the enteric fever. Cephalosporin, that is causing disulfiram-like reaction. This answer I have already given you. These are drugs like C4T and C4mandol. In the previous slide, I have already given you answer to this question. Okay, answer to this question I have already given for all of you guys. Okay. Then don't forget the important drug of choice in malaria. ये क्वेश्चन से, इस टेबल से एक क्वेश्चन आप एक्सपेक्ट करिएगा, एंड दिस विल बी द लास्ट टेबल फॉर द डे. This will be the last table for the day. Please do remember about this one. One will be chloroquine sensitive falciparum. Chloroquine sensitive अगर हो जाए, so definitely we will be using chloroquine. But nowadays we are having most of them that are resistance. Now we will be using artemisinin combination therapy depending on from which side the patient is coming. If the patient is coming from, let's say, northeast state, then we are going to use artemether plus lumefantrine. And if the patient is coming from the rest of India, any other part of India, then we are going to use artesunate plus sulfadoxine pyrimethamine, ASP. With both of them, we will also be using primaquine as a single dose on day 2. Please do remember, primaquine single dose on day 2, it is done mainly in the falciparum. Don't forget, falciparum has fal wala shape gametocyte. Fal is banana. Banana is the fal, right? So banana shaped gametocyte will be seen with the falciparum, falciparum. So examiner can give you a HP, a peripheral blood smear as well, and from there you have to choose the drug, which is very high chances in the upcoming examination there will be a peripheral blood smear, because integrated अगर पैथो से करना होगा, so that is one of the very simple and definitely asked topic. Chloroquine with the primaquine if the patient is having Vivax malaria. So definitely Vivax के लिए अभी भी chloroquine is sensitive. What is the difference between the primaquine here? Primaquine is a single dose. We will be giving here 45 milligram in the falciparum, but in the Vivax we are going to use 15 milligram per day into 2 weeks for the radical cure, है ना. Severe malaria में, or sometimes they use the term cerebral malaria, IV artesunate will be the preferred agent. Pregnancy में quinine with clinda we will be using in the first trimester. Second, third trimester we can use artemisinin combination therapy. Again remember, primaquine is a drug that will be contraindicated. If it is Vivax, we can give chloroquine here as well, but primaquine is something that is contraindicated. Let's repeat. I said pregnancy में, if it is Vivax, we will be giving weekly chloroquine 300 mg throughout the pregnancy. ठीक है? Vivax over, done. Falciparum first trimester में quinine and clinda. Second, third trimester में artemisinin combination therapy, but unlike other adult population where we are using primaquine, here we will not be giving primaquine. Pregnancy में नहीं देंगे. But if it is severe malaria, or we also call complicated malaria, cerebral malaria, IV artesunate will be used. Then after 48 hours, when the patient regain consciousness, you can shift the patient again to the oral. Prophylaxis, doxycycline, shorter term prophylaxis for the less than 6 weeks, long term prophylaxis के लिए we will be using mefloquine as a drug. Very, very important. Do remember that doxycycline 100 milligram on the daily basis, it will be started 2 days prior, and this will be given 250 milligram per week. It will be started 2 weeks prior. This is ideal. And after the therapy for both of them should be continued till 4 weeks after in both the scenario. So examiner has asked this, that after the journey, for how many days the person should take the anti-malarial prophylactic agent. Do remember, he or she should take for a total duration of at least 4. लास्ट थिंग, जहां से अगेन एक क्वेश्चन में स्क्वीज डाउन कर सकता हूं 2 मिनट में एक क्वेश्चन, प्लीज देख लीजिएगा. ये एक बार मैं बता रहा हूं, थ्रोम्बोक्सिन A2 इनहिबिटर विल बी नन अदर देन योर ड्रग लाइक एस्पिरिन. 2 मिनट्स में 1 क्वेश्चन स्क्वीज डाउन, पक्का पक्का एक क्वेश्चन पक्का लिख के ले लो. थ्रोम्बोक्सिन A2, टेरोट्रोबैन, रिमेंबर टेरोट्रोबैन क्लिनिकली नॉट यूज, सो यू डोंट हैव टू रीड इट आल्सो. टिक्लोपिडीन, क्लोपिडोग्रेल, प्रासुग्रेल, they are the P2 Y12 inhibitor. They are also the receptor ADP. Do remember that they are the irreversible inhibitor and these are the reversible inhibitor. So what you need to remember that cangrelor ये कैनुला से देते हैं तो IV वाला हो गया. टिकाग्रिलोर चिकन टिक्का, पनीर टिक्का ओरली खाते हैं तो ओरल वाला हो गया. As I said, last 2 minutes will give you 1 mark and I promise this will be the last slide. 2 स्लाइड है लास्ट के, 1 मार्क्स ले लिए. जल्दी से रिवाइज कर लीजिए. P2 Y12 is a receptor of ADP. टिक्लोपिडीन, क्लोपिडोग्रेल, तो ग्रेल के जैसा तो कैंग्रेलोर भी है, टिकाग्रेलोर भी है, बट टिका चिकन टिक्का ओरली, कैनुला से देंगे कैंग्रेलोर. दे आर द रिवर्सिबल एजेंट, है ना, दे आर द रिवर्सिबल एजेंट. देन यू शुड नो क्लोपिडोग्रेल का एक इंपॉर्टेंट पॉइंट, दैट दे आर प्रो ड्रग एंड दे गेट एक्टिवेटेड बाय अ माइक्रोसोमल एंजाइम, CYP2C19. और ओमेप्राजोल और इसका इंटीग्रेशन प्लीज डोंट फॉरगेट, बिकॉज they will be inhibited by omeprazole. So they are usually contraindicated with omeprazole, not with other PPI but especially omeprazole. कौन सा contraindicated with omeprazole? मैं बात कर रहा हूँ clopidogrel will be contraindicated with the omeprazole. Okay. Abciximab, tirofiban, eptifibatide, these are what? GP2B3 inhibitors. So examiner will be using the term not GP2B3. एग्जाम में बोलेगा विच ऑफ द फॉलोइंग एंटीप्लेटलेट ड्रग डिक्रीजेस द प्लेटलेट का क्रॉस लिंकिंग, डिक्रीज द प्लेटलेट का क्रॉस लिंकिंग. सो एब्सिक्सिमैब, टिरोफिबैन, बी और ए है ना, एब्सिक्सिमैब, टिरोफिबैन, एप्टिफिबाटाइड. एटोपक्सार, वोरापक्सार, डू रिमेंबर दीज आर द प्रोटीएज एक्टिवेटेड रिसेप्टर इनहिबिटर. प्रोटीएज एक्टिवेटेड रिसेप्टर इनहिबिटर विल बी एटोपक्सार, वोरापक्सार. Last slide, anticoagulants. Definite question. What is enoxaparin? These are the low molecular weight heparin. Fondaparinux, idraparinux, they are also like low molecular heparin, but they are the synthetic 10A inhibitor. They are also the indirect. But this apixaban, rivaroxaban, 10A पे ban लगाने वाले drug, they are the direct 10A inhibitor. Direct 10A inhibitor. Hirudin, lepiridine, they are the direct 2A inhibitor. Direct thrombin inhibitor. What about heparin? Heparin can also inhibit 2A or 10A, but they are indirect. Heparin is going to increase the activity of antithrombin 3, right, which will actually bind your 2A and 10A. So that is why we say heparin is an indirect thrombin inhibitor. Heparin को क्या बोलते हैं? Indirect thrombin inhibitor. And I think in the very first slide today, I have already given you the antidotes. So identifying the class of drug, identifying if there is overdose, what is the antidote we'll be using. Like for example, if there is overdose of apixaban, edoxaban, betrixaban, we'll be using andixanet alpha. Andixanet alpha is the antidote of choice that we are going to use. So एक छोटा सा टॉपिक छूट रहा था, that was hematology, which I have also covered for all of you guys. Pantoprazole, rabeprazole, they are safer with the clopidogrel. Do remember that. Okay. So I hope all of you guys can easily do this. And for all those who have joined late, I have already discussed with you the important antidotes. और मैंने बताया भी था कि हेमाटोलॉजी के एंटीडोट्स आई हैव गिवन यू हियर. इफ यू हैव सीन, राइट, दिस इज द वन दैट आई हैव ऑलरेडी गिवन टू ऑल ऑफ यू गाइस. सो इफ यू सी रफली, आई हैव टेकन यू थ्रू मोस्ट ऑफ द टॉपिक्स लाइक जनरल फार्मा, ANS, इंपॉर्टेंट पॉइजनिंग, एंटीडोट्स, हेमाटोलॉजी हो गया, है ना, इंपॉर्टेंट मोनोक्लोनल एंटीबॉडीज, इम्यूनोमोडुलेटर्स एज वेल, गाउट, रूमेटॉइड आर्थराइटिस में भी गए. थोड़े बहुत एंटीमाइक्रोबियल किया जो इंपॉर्टेंट था, लाइक मलेरिया एंड your anti-tubercular drugs, important antibacterial as well we have seen, and a couple of other topics which was like endocrine and all we have also covered today. So this was a very quick review for our today's session, and believe me, if you have gone through this one, we will expect good number of questions. Just एक बार please इसको देख लेना. मैं अभी आपको थोड़ी देर में PDF शेयर करूंगा. Just within few minutes you will be getting the PDF. Please don't forget to go through this one. Don't panic at all. If you have listened to me, if you have heard these stories, mnemonics, or if you have gone through these, you will definitely get to mark in the examination. Have faith in yourself. Believe me, you will not miss these questions. Important questions. और आपके एग्जाम में मैं फिर से बोल रहा हूँ, more than 60% क्वेश्चन मैं entire बात कर रहा हूँ, मैं सिर्फ फार्मा की बात नहीं कर रहा हूँ. I am talking about the entire thing. More than 60% of the question will be in a way which an average student can do. This is what on the basis of previous experience as well we have seen, and we will be expecting a good passing percentage in this examination as well. Okay. So I hope all of you guys have enjoyed the session of this 3 hour. As I said, I'll be taking only 3 hour, and in this 3 hour roughly मैंने आपको एक overview दे दिया. Please go through this one and expect अगर 3 घंटे के सेशन से मेरे सेशन से 10 नंबर भी आता है ना, believe me, this is a very win-win situation. Each one of you will rejoice this 10 marks. But I'm expecting, let's say if it is more, definitely it will be win-win situation for all of them, all of you. ठीक है, चलो bye bye to all of you. Have a good night. If there is anything, right, I'm just one click away from all of you guys. Any doubt, any controversy, you can just message me. And all the very best for your examination. Just relax, read whatever you have read. If you have not read anything, at least this 3 hours का तो काफी हो गया, इसमें आप करिए. Definitely you will get good number of questions from these topics that we have discussed. ठीक है. Okay, thank you very much. काफी बच्चों का एडमिट कार्ड नहीं आया. I have seen lot of students are messaging me as well, but I have advised them to message NB, because those guys are the one, those people are the one that can help something. If there is anything that we can do, please let us know. We can share your post and all. Just let us know. Just send us across, and definitely we will help you out in whatever way we can. ठीक है. Alright, मजा आ गया. ठीक है. So I hope बाकी सब लोग भी enjoy किए होंगे. So please don't let this whatever hard work that we have done in 3 hours, don't let this go in vain. Please spend at least 1 से 1.5 घंटा और spend कर लो, and believe me, you will enjoy solving pharmacology in the examination. चलो, bye bye to all of you. Have a good night.